Good morning, everyone. Welcome to the 2021 Infant Mortality Awareness Summit. Before we begin our presentations today, we will have greetings from our sponsors at the Alabama Department of Public Health, Birmingham Healthy Start Plus, and the Gift of Life Foundation. Thank you.
Good morning, everyone. Welcome to this fourth annual Infant Mortality Summit, hosted by ADPH, by the Gift of Life Foundation, and by Birmingham Healthy Start Plus. I'm Scott Harris, and I serve as State Health Officer with Alabama Department of Public Health. And I just want to thank you very much for joining us today on this event with the theme of Strengthening Communities, Tools to Promote Better Birth Outcomes. We have spent a lot of time in the last year and a half talking about one subject in particular, but today we're here to talk about infant mortality and maternal mortality, which are issues that we have long dealt with in our state, which have long been trouble for us here in our state, and for which you are all here today because you care so much about this issue. Alabama's infant mortality rate in 2019 was about 7.7 per thousand live births. That's one of the best infant mortality rates we've seen actually in my lifetime. And yet we still have a long way to go. That's compared to the US infant mortality rate of 5.7, which in itself is not a very good rate compared to most developed countries in the world. So we certainly have a lot of room for improvement in spite of some of the improvement that we've seen recently. I certainly want to remind you, or I don't have to remind you, that we have tremendous racial disparity in our infant mortality rates nationally, but in Alabama in particular. Infant mortality rates among Black Alabamians are about twice what they are for white Alabamians. And I just have to say, in this day and time, that's just not something that is acceptable to us and something that we need to continue to work on. We continue to see racial disparities related to maternal mortality as well. The number of deaths among Black moms from maternal causes is about 2.5 times higher than in white moms, or 3.5 times higher than in Hispanic moms. And again, this is just a disparity that we ought not to accept and that we need to continue to work on. So we certainly are doing a lot of things. You're going to hear a lot about that today. We continue to have an improving pregnancy outcomes project as part of ADPH's strategic plan, one of the 5 thrusts of our overall departmental strategic plan. We continue our efforts with perinatal regionalization, which you'll hear more about as well. The governor's initiative on infant mortality continues strong in Macon, Russell, and Montgomery counties as well. And we've also expanded our All Babies program through our Children's Health Insurance program into those counties as well. So we do have many exciting things going on. The purpose of the summit really today is just to give you an opportunity to learn about those things, to get a better understanding of the social and environmental factors that affect maternal mortality and infant mortality, and then help us all learn how to work together so that we can be partners in understanding the root causes and understanding how we can address these issues that are so important to all of us. So again, thanks very much to all of you for being here. We really appreciate your time and participation. Hope you have a good time today.
Thank you, Dr. Harris.
Good morning, everyone. Greetings. It is my pleasure to welcome you to the State of Alabama 2021 Infant Mortality Summit today. The goal for today is to offer you information, tools, and resources to promote better birth outcomes in your community. So although we are making strides in the state of Alabama to reduce infant mortality, the rate of death remain higher than the national average at this time. So it is imperative for us to continue to provide education and resources and work together, partner for the future of our babies. We're looking forward to this time together with you today. Thank you.
Thank you, Dr. Traylor.
Hello, everybody. This is Rick Green, Birmingham, CEO of Birmingham Healthy Start Plus. And I also would like to welcome everybody to our 4th annual Infant Mortality Awareness Summit. So we've already been told what the purpose of today's event is. And so I won't repeat that. But I would like to thank everybody for taking out the time, joining in with us as we recognize September as Infant Mortality Awareness Month. And as we look at avenues and ways that we can address infant mortality as a state, also from a community-based level and in partnership with community organizations. So once again, as with everybody else, I would like to say welcome to our 4th annual Infant Mortality Awareness Summit.
Thank you, Mr. Green. Okay, my name is Samil Jackson, and I'm the Maternal and Child Health Coordinator at ADPH, and we will begin our program today with a presentation from the Centers for Disease Control and Prevention. We will have Dr. Suzanne Gilboa and Dr. Danielle Ely giving us some information about birth defects, infant disorders, and other resources that they have and data resources they've done at the CDC. Thank you.
Hi, Samil. Can you hear me?
Yes, Dr. Ely, I can hear you.
Fantastic. Well, I'd like to start by thanking you for having us today. Obviously, infant mortality and pregnancy outcomes are very important to us being in our positions. And I'm happy to start sharing my presentation. So today I'm going to be talking about infant mortality in the United States as a whole, and specifically in Alabama. Since 1995, when the period-linked file was created, the overall infant mortality rate in the United States has gone down about 19%. That said, there are several differences that you can see between the US infant mortality rate and the infant mortality rate in Alabama. Specifically, the Alabama rate in 2019 is 38% higher than what the infant mortality in the United States is as a whole, the difference being about 7.71 compared with 5.6. To start, I'm going to discuss some of our definitions of live birth, fetal death, and infant death. To start, how is live birth defined? So we follow the model law definition, which means that a live birth is defined as the complete expulsion or extraction from its mother of a product of human conception, irrespective of the duration of pregnancy, which after such expulsion or extraction breathes or shows any other evidence of life, such as the beating of the heart, pulsation of the umbilical cord, or definite movement of voluntary muscles. In this definition, heartbeats need to be distinguished from transient cardiac contractions, and respirations are to be distinguished from fleeting respiratory efforts or gasps. Fetal death is defined as a death prior to the complete expulsion or extraction from its mother of a product of human conception, irrespective of the duration of pregnancy, and which is not an induced termination of pregnancy. The death is indicated by the fact that after such expulsion or extraction, the fetus does not breathe or show any other evidence of life, such as the beating of the heart, pulsation of the umbilical cord, or definite movement of voluntary muscles. How is infant death defined in this case? For an infant death to occur and to not be a fetal death, there must be a live birth, which is followed by a death before 365 days of age. Within infant deaths, we have two classifications, neonatal and postneonatal. For neonatal, the death occurs within 28 days of age. Early neonatal deaths are those occurring within 7 days of age, and late neonatal deaths are those occurring between 7 and 28 days of age. Post-neonatal infant deaths are those deaths occurring between 28 and 364 days of age. For this presentation, I have chosen some selected known risk factors to compare between the United States and Alabama. Some of these include maternal race and Hispanic origin, maternal age, marital status, the timing of prenatal care, Medicaid, which is a potential socioeconomic status indicator, preterm births, which are those births that occur at less than 37 completed weeks of gestation, and low birth weight, which are those births that are those infants that are born at less than 2,500 grams. So based on the maternal race and Hispanic origin, in Alabama, a greater percentage of births are born to non-Hispanic white women and non-Hispanic Black women compared to the entirety of the US. And these, it's about 13% higher for non-Hispanic white women and 112% higher number of births to non-Hispanic Black women. There are about 65% lower for Hispanic women in Alabama compared to the United States. In Alabama, the percent of births to teen moms is about 48% higher, and births to unmarried women is about 21% higher compared to the United States. This slide is showing the percent of births by the timing of prenatal care and those births that use Medicaid as the source of payment for delivery. In Alabama, there aren't dramatic differences in terms of those who receive care, prenatal care in the first trimester. It's about 9% lower than that in the United States, about 71%. However, the percent of births that received prenatal care in the third trimester or received no prenatal care was 23% higher at almost 8%. In terms of those moms who used Medicaid for the source of payment, in Alabama, the percent was about 18% higher at almost 50% of births. In terms of preterm births and low birth weight, Alabama had slightly worse outcomes than the rest of the United States in general. So for preterm births, it was about 23% higher at 12.5% of births being preterm. And for low birth weight, about 10.5% of births were low birth weight, which is about 27% higher than that of the United States. When looking at the fetal, perinatal, and infant mortality in the United States and Alabama, so the fetal mortality rate in Alabama is substantially higher than that of the United States. It was about 56% higher, and the number of deaths per 1,000 live births was nearly 9, so it was 8.89 fetal deaths per 1,000 live births. For the perinatal mortality rate, this is a little bit better than what the fetal mortality rate is. However, it's still 27% higher than that in the United States. And so there were about 7.24 perinatal deaths per 1,000 live births in Alabama in 2019. When looking at the infant mortality rate by maternal race and Hispanic origin, the infant mortality rate was higher for each of the 3 race and Hispanic origin groups that we address here. For non-Hispanic white women, their infants had a 27% higher infant mortality rate than that of the US at 5.72. For non-Hispanic Black women, the rate was 11.6, which was about 9% higher than the rate for the US. And for Hispanic women, the rate was 7.54, which is about 50% higher than that in the US. Alabama, compared to the rest of the United States, you can see here, was 49th in the nation with the rate of 7.71. And if you think back to the first slide, I added in the 5.58 infant mortality rate for the United States. So overall, Alabama, compared with the United States as a whole, Alabama births were more likely to be to teen mothers, unmarried mothers, those with late or no prenatal care, and to mothers for which Medicaid was the source of payment for the delivery. Alabama infants were more likely to be born preterm and low birth weight. And the Alabama fetal, perinatal, and infant mortality rates ranged from 27 to 56% higher than the United States in 2019. Finally, the Alabama infant mortality rate was 49th highest in the nation between all states and the District of Columbia. And I actually believe we are taking questions at the end, if I remember correctly. So I will stop here. And if anyone has any questions, please feel free to share them with me after my colleague is done.
Thank you, Dr. Ely.
Good morning, everybody. Can everybody hear me and see my screen? Perfect. Thanks, Danielle. I'm seeing your face, so I'm knowing that things are going okay. Good morning. My name is Suzanne Gilboa, and I'm an epidemiologist in the National Center on Birth Defects and Developmental Disabilities in the Division of Birth Defects and Infant Disorders. And thank you, Dr. Ely, for setting the stage by presenting the state-specific and national data. We're going to transition into talking about some of the leading causes of infant mortality and what two divisions at CDC, my division, Division of Birth Defects and Infant Disorders, and our sister division, the Division of Reproductive Health, are doing to address them. Dr. Charlene Krolinger is also on the line and will help us address questions during the discussion that people may have specifically around the Division of Reproductive Health work. In the United States, the 5 leading causes of infant mortality are birth defects, preterm birth and low birth weight, maternal pregnancy complications, sudden infant death syndrome, and unintentional injuries. We're going to first take a look at the impact of birth defects and how CDC tracks to prevent them. Birth defects account for about 20% of all infant deaths. A 2020 paper, the plot from which is shown here, showed the rates of infant deaths due to birth defects had decreased 10% overall during the study period. However, despite the overall decline, disparities persist, potentially due to access to and utilization of healthcare before and during pregnancy, as well as other factors. This report underscored the need to continue identifying potential risk factors for birth defects and finding opportunities to prevent them. We know that not all birth defects can be prevented, but we also know that women can increase their chances of having a healthy baby by managing health conditions and adopting healthy behaviors before becoming pregnant. Our Division of Birth Defects and Infant Disorders is committed to reducing infant deaths by working with healthcare providers, communities, and other partners to address the social, behavioral, and health risk factors that contribute to birth defects and infant mortality. We also use tracking and research to identify causes of birth defects, find opportunities to prevent them, and improve the health and survival of all babies with these conditions. Through surveillance and case control studies, we work to identify causes of birth defects and find opportunities to prevent them. Accurately tracking birth defects and analyzing the collected data is a first step towards prevention. Although 43 states in the US have birth defects tracking programs, they have a wide range of capabilities, and not all can gather consistent or usable data. CDC is currently funding 10 population-based state programs highlighted here in blue on this map. Birth defect surveillance data have been used to better understand mortality, as well as morbidity, associated costs, and how those vary by specific defect and by race ethnicity. Data are also used to refer babies and families to clinical and developmental services, as well as inform prevention activities. For referral, birth defects tracking programs provide one way to identify for children for services they need as early as possible. Early intervention is vital to improving outcomes for these babies. And knowing how many babies have birth defects helps policymakers allocate resources and services to help affected children and their families. And for prevention, data about where and when birth defects occur and who they affect help us identify factors that can increase or decrease that risk for birth defects and identify community or environmental concerns that need more study. Our group coordinates multi-site case control studies to identify risk factors and causes of birth defects. The Centers for Birth Defects Research and Prevention are research centers across the nation funded by CDC. These centers have been conducting the largest studies of birth defects ever undertaken in the United States, the National Birth Defects Prevention Study. The centers built upon the success of the NBDPS to further examine promising findings with a new study, the Birth Defects Study to Evaluate Pregnancy Exposures, or BD STEPS. Findings from research studies are used to inform clinical practice. For example, the Committee on Obstetric Practices of the American College of Obstetricians and Gynecologists wrote a piece on drug use for urinary tract infections and birth defects based on data from this study. Findings from the research are also used to confirm previously observed associations, generate new hypotheses for further study, identify areas for prevention, and of course, provide information to the public. In the next couple of slides, I'm going to focus on two specific defects, spina bifida and congenital heart defects, with a primary focus on primary and secondary prevention. The survival of infants born with spina bifida has improved over time. However, improvements in survival have varied by race ethnicity, and Black and Hispanic infants continue to have poor survival compared with white infants. The CDC, Institute of Medicine, and U.S. Preventive Services Task Force all recommend that women of reproductive age take folic acid to help prevent neural tube defects. And because of folic acid fortification in the United States, about 1,300 babies are born each year without a neural tube defect. But neural tube defect rates are still higher among Hispanic populations. To address this disparity and try to reduce neural tube defects among Hispanic women, CDC and partners petitioned and were successful in getting FDA approval for voluntary folic acid fortification of corn masa flour in April of 2016. CDC also conducts public health research to decrease mortality and improve the health of those living with spina bifida. We fund and manage the National Spina Bifida Patient Registry. The registry gathers data from children and adults who receive care at spina bifida specialty clinics. These data help us understand more about the care received and the impact of care and services on health outcomes and quality of life. Evaluation of this information leads to improvements in the care and treatment of spina bifida. Turning to congenital heart defects, or CHDs, these are the most common type of birth defects, affecting nearly 1 in 110 births in the United States. Survival of babies born with a non-critical congenital heart defect is very good, 99% up to year 1, and about 95% up to age 18. 1-year survival for infants with critical congenital heart defects, however, is somewhat lower. It has improved tremendously with surgical and clinical advancements over the last 30 years. According to a recent report, survival during the period from 1979 to 1993 was 67% and increased to over 80% in the period from 1994 to 2005. One of the clinical advances is newborn screening for critical congenital heart defects using pulse oximetry. Using pulse oximetry, infants with certain critical congenital heart defects can be identified before they leave the hospital, thereby contributing to the reduction in infant mortality. Using data from death certificates, CDC and collaborators showed that mandated critical congenital heart defect screening using pulse oximetry reduced early infant deaths from critical CHD by 33%, or 120 early infant deaths were averted each year due to screening. He has worked with his partners to track state implementation of screening for critical congenital heart defects, which has now been implemented nationwide. And CDC conducts public health research to improve health and reduce mortality among those living with heart defects. We're now going to look at some of the work from CDC's Division of Reproductive Health. The Division of Reproductive Health is focused on reproductive, pregnancy, and infant health, and their programs strive to improve fetal, newborn, and infant health by reducing morbidity and mortality, and by reducing the burden of preterm birth, improving the health of the fetus and newborn through optimal care before, during, and after pregnancy, and reducing sudden unexplained infant death, or SUID, through surveillance and reducing disparities. One important thing to note here is that CDC is more and more aware of how connected the health of the mother and the child are. It's critical that we look at maternal and infant health together. Improving the health of mothers will improve the health of infants. The Division of Reproductive Health at CDC is committed to improving birth outcomes and addressing non-birth defects related causes of infant mortality. This requires public health agencies working together with healthcare providers, communities, and partners to reduce infant deaths in the United States. This joint approach can help address the social, behavioral, and health risks that affect birth outcomes and contribute to infant mortality. We're working to better understand and reduce infant mortality by collecting more robust data, including data on social determinants of health, and tying that data to action. We collect data on emerging topics through PRAMS, the Pregnancy Risk Assessment Monitoring System. PRAMS collects state-specific, population-based data on maternal attitudes and experiences before, during, and shortly after pregnancy. PRAMS data can be used to identify groups of women and infants at high risk for health problems and to measure progress towards goals in improving the health of mothers and infants. We're also working to improve our understanding of sudden unexpected infant death, or SUID. Division of Reproductive Health has SUID monitoring programs in 22 states and jurisdictions, covering about 1 in 3 SUID cases in the US. Participating states and jurisdictions use data about SUID trends and circumstances to develop strategies to reduce future deaths. The Sudden Unexpected Infant Death and Sudden Death in the Young Case Registry brings together information about the circumstances associated with these deaths, as well as information about the investigation into these deaths. We used all of this data to inform efforts of the Perinatal Quality Collaborative, or PQCs, to support quality, standardized care for women and children. PQCs are state or multi-state networks of teams working to improve health outcomes for mothers and babies. Funding supports the capabilities of PQCs to improve the quality of perinatal care in their states, including efforts to reduce preterm birth and improve prematurity outcomes. CDC works with experts to develop resources for PQCs to use to further their development. CDC and the March of Dimes also launched the National Network for Perinatal Quality Collaboratives, which expands the reach of lessons learned onto a national scale. The National Institute for Children's Health Quality currently serves as the coordinating center for the NNPQC. Another tool we have for improving access to quality care is CDC Locate. Locate helps states and other jurisdictions assess the systems of risk-appropriate care in their regions, enabling them to show the capabilities and staffing services within levels of maternal and neonatal care among delivery facilities. Locate is building better systems to improve how we care for mothers and infants. And finally, we build support to improve maternal and child health. The Maternal and Child Health Epidemiology Program assists epidemiologists and fellows in states, localities, and tribes to support epidemiologic research and provide scientific information to improve maternal and child health programs and policies. Through this program, which we partner with AMCHIP, we developed the State Infant Mortality Toolkit to help states, counties, tribes, and urban areas analyze infant mortality data and translate those findings into programs and policies to reduce infant mortality. I'd like to share an example of how perinatal quality collaboratives have worked to improve outcomes. Appropriate fetal and newborn interventions at the time of delivery and immediately after delivery are critical to improve infant outcomes. Several PQCs have implemented golden hour initiatives to improve outcomes of infants requiring resuscitation and stabilization by implementing evidence-based practices in the first hours of life. Those interventions include delayed cord clamping, thermoregulation, and oxygenation, and require well-coordinated care among the services and providers, particularly within the first 90 minutes of life, which is referred to as the golden hour. In Illinois, the Golden Hour Initiative resulted in a 70% reduction in moderate to severe hypothermia in NICU admissions. They also increased the use of a checklist to improve best practices in neonatal resuscitation care from 46% to 90%. The Mississippi and Florida PQCs have also implemented golden hour initiatives to improve infant care and outcomes. And of note, the Alabama Perinatal Quality Collaborative is a member of the National Network of Perinatal Quality Collaboratives. Sudden unexpected infant death, or SUID, is a common cause of infant mortality. Data from the National Vital Statistics System showed that about 3,600 babies in the United States die suddenly and unexpectedly each year. Although the SUID rate has declined since the 1990s, significant racial and ethnic differences continue. This chart shows SUID rates by cause and by race ethnicity in the US between 2014 and 2018. Causes include sudden infant death syndrome, unknown cause, and accidental suffocation and strangulation in bed. As you can see, SUID rates per 100,000 live births for American Indian and Alaska Natives and non-Hispanic Black infants were more than twice those of non-Hispanic white infants. A recent publication from CDC's SUID case registry provides more insight into why sudden infant deaths are occurring. Findings show that nearly 3 in 4 SUID cases occur in unsafe sleeping circumstances, though only about 1 in 5 cases could be explained as a death resulting from suffocation. Most of these explained deaths were attributable to soft bedding, occluding the infant's airway. Although these explained deaths constitute a small proportion of SUID, these deaths are nearly always preventable. Continued improvements in autopsy and death scene investigation and documentation are critical to understand the sleep environment's role in infant deaths. And such improvements are imperative to further developing safe sleep guidelines and educational efforts to eliminate SUID throughout the US. Another recent study published in the Journal of Pediatrics analyzed data from CDC's PRAMs to assess trends in racial disparities in rates of supine sleep positioning, or infants being placed on their back during sleep time, among preterm infants. Findings show that from 2000 to 2015, supine sleep positioning rates increased across all racial and ethnic groups of early preterm and late preterm infants. Improvements in these rates was larger among early preterm infants than late preterm infants, and this could be attributable to NICU-based efforts to integrate safe sleep practices into the routine care of preterm babies during a prolonged hospitalization. But despite these improvements, racial and ethnic differences in supine sleep positioning among early preterm and late preterm infants persists. So what can we do to better understand and reduce or eliminate the barriers and facilitators to safe sleep practices within a racial equity framework, particularly for African American Indian, Alaska Native, and Black families who continue to experience the greatest risk of SUID in the US? It's important to view every infant and caregiver encounter as an opportunity to teach and re-emphasize safe sleep basics. This infographic on 4 tips for parents and caregivers is from a recent vital signs report from the Division of Reproductive Health on safe sleep for babies. Also, involvement in and cooperation with local child death review is so important. Clinicians have a different lens on the life of the child, and their family can be extremely valuable in reviewing all of the factors associated with the death. Combined with info gathered after a death, this can help uncover why a child died and suggest how similar deaths might be prevented in the future. In this last part of the talk, I'm going to transition to speaking about a few additional areas in which CDC works that impact infant health and mortality, including substance use during pregnancy and emerging infectious threats. Opioid use during pregnancy is associated with poor fetal growth, preterm delivery, stillbirth, and specific birth defects, and can cause neonatal abstinence syndrome, or NAS. In addition, alcohol use during pregnancy is associated with miscarriage and stillbirth, preterm delivery, sudden unexplained infant death, and is a cause of fetal alcohol syndrome, or fetal alcohol spectrum disorders. And data suggests that the use of more than one substance, which is known as polysubstance use, during pregnancy is rather common. But more work is needed to really understand the possible effects of multiple exposures as distinct from one exposure, which is alcohol or opioids during pregnancy. CDC is involved in several projects aimed at addressing opioid use during pregnancy. The Division of Reproductive Health is currently collaborating with the American Academy of Pediatrics on the Maternal Infant Health and Opioid Use Project, which aims to improve the quality of care of infants exposed to opioids prenatally or with NOWs, and of pregnant and parenting women with opioid use disorder. The project develops and promotes educational tools and resources that support the patient and the family-centered care framework, including linkages to services for infants with prenatal opioid exposure and linkages to care and treatment for women of reproductive age with opioid disorder, as well as also addressing negative social attitudes and stigma towards pregnant women and parenting women. The Division of Birth Defects and Infant Disorders has established MATLINK, a surveillance system to monitor maternal, infant, and child health outcomes associated with the treatment for opioid use disorder during pregnancy. Results will inform clinical practice recommendations and clinical decision-making around treatment for OUD among pregnant people. Both of these projects aim to better support and care for infants born with opioid exposure during pregnancy in order to mitigate negative outcomes. The Division of Birth Defects and Infant Disorders also aims to prevent alcohol use during pregnancy through implementation of alcohol screening and brief intervention approaches, and awareness and education efforts for women of reproductive age and their healthcare providers. Alcohol screening and brief intervention have been shown to reduce risky alcohol use in a variety of settings and among multiple populations. It's recommended by the U.S. Preventive Services Task Force for people 18 and older, including pregnant women, and widely supported by federal agencies, medical groups, and professional organizations. CDC promotes alcohol screening and brief intervention in three main ways. First, by developing tools and workflows for clinics to integrate alcohol screening and brief intervention into primary care settings. Second, by developing a quality improvement resource for health plans to improve reporting of the HEDIS measure, unhealthy alcohol use screening and follow-up. And third, by developing messages for healthcare providers to emphasize the importance of providing alcohol screening and brief intervention and developing resources and tools to enhance patient-provider communication about alcohol use and its risk during pregnancy. In addition to known risk factors like alcohol and substance use, CDC studies and tries to mitigate the impact of new and emerging threats to mothers and their infants. With the Zika outbreak in 2016, we realized there were previously unknown threats that could have a major impact on the health of mothers and babies. Building on the work done during the Zika response, CDC established the Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet, which is a mother-baby linked longitudinal surveillance system that's designed to detect the effects of new health threats, most recently, for example, COVID-19, on pregnant people and their babies by collecting data from pregnancy through early childhood, and to use evidence-based actionable information to help save and improve the lives of mothers and babies. Currently, SETNet funds 31 jurisdictions across the United States, which represents 2.3 million live births. We began with 13 jurisdictions funded to collect mother-baby linked longitudinal data on Zika, congenital syphilis, and perinatal hepatitis C in 2019, and then rapidly expanded in 2020 to include COVID-19. SETNet has provided for the development of a critical public health preparedness and response infrastructure, enables CDC and health departments to explore and address a multitude of current and future emerging threats, and strengthens the public health workforce and technology required to facilitate more timely and accurate data in order to have guidance to address the needs of pregnant individuals and their infants before, during, and after an emergency. With respect to our SETNet COVID-19 work, the national case surveillance data only collected pregnancy status, and thus in April of 2020, we expanded SETNet to obtain critical additional information on the timing of infection, obstetric risk factors, and birth and infant outcomes that were not available in other COVID-19 data sources. SETNet is following women with lab-confirmed SARS-CoV-2 infection at any point in pregnancy, up to and including the day of delivery. Up until this time, we have limited surveillance to infections during the calendar year 2020, but we are planning to expand that to 2021, given the Delta variant and the turn that the pandemic took earlier this summer. SETNet surveillance sites follow women until pregnancy outcome and abstract data from existing data sources, and some sites will also follow children up to age 6 months. This slide is showing a snapshot of SETNet data as of July 2021. The COVID data tracker website is updated every month with new information on pregnancy and birth outcomes among women with confirmed SARS-CoV-2 infection in pregnancy. As of July, nearly 60% of the infections in the surveillance system were third trimester, and we have 12% in the first trimester and 31% in the second trimester. And the prevalence of preterm birth in that cohort was about 12%. This is the Epi Curve of lab-confirmed cases among all pregnant women, and this is based on nearly 110,000 cases in the national case surveillance data. These data have much less detail than our SETNet data, but it is national in scope and gives you a good sense of the magnitude of the pandemic in pregnant women. As you can see, there were several peaks in late March and early April, July, and then December, and now again in the summer of 2021. There are reporting lags in these data, so we consider about a 2 to 4 week lag in the data in terms of ascertaining pregnancy status. And though the national cases are order of magnitude higher than the pregnant cases, this pattern is very similar to the pattern nationwide among all individuals. SETNet data has helped further our understanding of the risk of COVID-19 to pregnant women. Current data indicate that an increased risk of ICU admission, mechanical ventilation, and ECMO, all proxies for illness severity in pregnant women compared to non-pregnant women. Our newest data also indicate an increased risk of death. And although the absolute risks of severe illness are low overall, pregnant women are at increased risk of severe illness compared with non-pregnant women with COVID-19. The data also suggests that preterm birth risk is somewhat higher than expected rates among pregnant people with COVID-19, and pregnancy loss, specifically stillbirth, has been observed with some evidence that it may be higher than expected among pregnant people with COVID-19. Finally, I want to briefly touch on one last topic. As Danielle Ely alluded to, we can't really talk about infant mortality without also talking about fetal mortality. In the United States, the annual number of fetal deaths or stillbirths at or after 20 weeks of gestation is approximately equal to the number of infant deaths. The National Center on Birth Defects and Developmental Disabilities has funded 2 of the Centers for Birth Defects Research and Prevention that I talked about earlier, Arkansas and Massachusetts, to better understand factors that might increase the risk for stillbirth. These states' birth defects tracking programs have been expanded to identify all pregnancies resulting in a stillbirth, not just those with a birth defect. And the research study, the birth defect study to evaluate pregnancy exposures, or BB steps, was expanded to have a component entirely focused on stillbirths without birth defects. Additionally, the Pregnancy Risk Assessment Monitoring System funded the Utah Department of Health to expand its PRAMS methods and sampling to include women who experience stillbirth. Having a clear picture of both infant and fetal death is critical to understand overall child survival and the global burden of disease. As Dr. Ely touched on when discussing rates of infant death, there are significant racial and ethnic disparities in fetal death as well. Compared to white and Hispanic mothers, Black mothers are more than twice as likely to experience a stillbirth. And compared to white mothers, Black mothers were more than 3 times as likely to have their baby die during late pregnancy due to a maternal chronic health condition or health problem that occurred during pregnancy. It is critically important for women to receive health care before and during pregnancy to decrease the risk of pregnancy complications. Knowledge about the potential causes of stillbirth can be used to create recommendations, policies, and services to help prevent stillbirth. And improvements in women's health with regular access to quality prenatal care can potentially reduce the risk of stillbirth for women and families of all races and ethnicities. CDC is dedicated to reducing health disparities and addressing social determinants of health to advance health equity. Knowledge about the potential causes of stillbirth can be used to create recommendations, policies, and services to help prevent stillbirth. Finally, I want to spend one slide on CDC's commitment to health equity. This new initiative is known as CORE. C is for cultivate the science around health equity. O is for optimizing our interventions. R is for reinforcing and expanding our partnerships. And E is for enhancing our workforce capacity and engagement. Each of the divisions at CDC has been identifying its health equity priorities. In my division, the Division of Birth Defects and Infant Disorders, one of our goals is to address the higher rate of neural tube defects in Hispanic women that I talked about earlier. And the other is to focus on health inequities among individuals living with birth defects and infant disorders, such as congenital heart defects, muscular dystrophies, and spina bifida. We're looking for drivers of inequities and working with our key clinical, public health, and maybe some non-traditional partners to describe, inform, and impact those drivers of inequities. So I'm going to stop here, and both Charlene Krolinger and I will be happy to answer any questions you have about CDC's work. Thank you.
Thank you to all of our presenters from the CDC. That was some great information. I know that it's sometimes difficult to hear how high our numbers are, how bad our numbers are. I know it looks negative, but it's great when we hear the ways that we can make changes and to see the research going into, we're getting some questions, the research going into moving those numbers in a positive direction. And I was happy to see some of the programs that CDC is doing, because I know that ADPH and Healthy Start and some of our other state partners are involved in some of those initiatives. You know, we do PRAMS, we have a perinatal quality collaborative, we're doing some work with opioid, neonatal abstinence syndrome. And of course, as a Title V grantee, we work with AMCHIP. So those are really positive to know that we are affecting change in our state and adding to the national data and the national look. So we do have a couple questions, and I hope I get these correct. So the first question was about and I'm not sure if you all can answer this. This is more about the effect on the moms as far as the birth defects, and then I guess the treatment options and how that impacts the maternal health. And if some of those defects also harm the mom's health. Anyone speak to that?
Sorry, where is the question? I think I missed it. Is it in the chat?
No.
Oh, okay. Okay, here. Increased preterm birth with COVID. Can you clarify this is one? Yeah, I don't think we know that yet.
Okay.
The issue is if mom gets very sick with COVID, then during pregnancy, then the probability of her having an adverse outcome is much higher. But we don't necessarily know if the potentially higher rate of preterm birth for moms with COVID is directly related to how sick the mom is, or a direct effect on the duration of the pregnancy. So we're really trying to tease that out. We're still working on that, and I think we'll know more in the next few months as we're able to analyze this data better.
Okay, and I think they were asking, thank you for that. That's good to know. I think they were asking about in general, but we will follow up and try to get them an answer about birth defects, because we always know how, mom's health affects baby, but I think people are asking about how babies affect moms. So we will follow up on that question. Thank you. Okay, so the next one is someone is asking how to find out more about the CORE initiative. Is there a website that we can share?
Yes, I will put a website. Should I put it in the Q&A?
Yes, in the chat box.
In the Q&A chat box. That one? Or in the chat box?
In the chat box, yes.
Okay. Yeah, I'll put it there.
Okay, everyone can see the chat box. Okay. So someone had a comment. They wanted to remind us that Alabama doesn't currently screen newborns for spinal muscular atrophy. But I believe that's something that we're working on. They put a link in for change.org. I know that we have expanded, our newborn screening program has expanded the things that we are screening for. We add them as they come about. So there may be something that will be added soon. Okay, someone else wanted to know about CORE, and thank you for sharing that link. Okay, we have another question that we will address later. I think that will come up. Someone is asking about education options for educating mothers. I know that it's a big part of what you all are doing to using that data to craft education. You mentioned, the safe sleep and SIS and things like that. So we do have some programs in Alabama that work to educate mothers, and we will share them with you throughout the day. It'll come up probably in our next panel where some of the programs that were mentioned in the CDC presentation, we'll get into a little more the specifics of what we're doing with things like March for Dimes and, like I said, Healthy Start. So are there any more questions for you're welcome, our CDC panelists? Will there be support provided to states for the implementation of some of the CORE initiatives?
I think so. On the website that I just put in the link to, there are funding opportunities for health equity at the state level. So I see that link as well. So I'm going to put that link right in the chat.
Thank you. Okay, let me see. Let me check my Q&A box because we have two different boxes here. Okay, that was where you talked about the increased PTB with COVID. Can you clarify this, if it's more inductions early due to health issues, or is it spontaneous?
Yes, that's what I tried to answer in the beginning. Okay. That was the question that I was answering.
Okay.
really know if it's, the severity of the maternal illness is really the driver, or it was, delivering intentionally early to protect the mom who's very ill. So we're trying to tease that out. It's really difficult to determine that in the data, but we are working on exactly that question because we really do need to know that.
Okay, next question. It's asking specifically about our state, but there may be some information you have that other states are doing, like some of the other ones that you were funding. Given the causes of infant mortality are multifactorial, what interventions, if any, have proven to be the most effective? They're asking what they can do on the local level.
Charlotte, do you want to handle that one?
Yes, thanks. Hi, this is Charlotte. I would say Dr. Gilboa mentioned in her presentation, but I think it's really important for those deaths that are occurring later in life for infants. It's really important to look at sleep surfaces. We think co-sleeping deaths are fairly high, and we recommend that be an area of focus at the local level. There have been interventions in states such as having caregivers understand issues with soft bedding, as well as law enforcement and other services reaching out in the community to help folks understand that it's the safest place to put an infant is on its back and on a surface without any other soft bedding or any other blankets or pillows. So I think that's a community-led effort that's really important. Also, we work with our perinatal quality collaboratives to develop interventions that can happen during delivery and immediately post-delivery for those earlier deaths. And Dr. Gilboa touched on those findings as well. The National Network of Perinatal Quality Collaboratives has a website that I think is provided in the slides, but we can also drop it in the chat, that highlights what other states are doing in terms of interventions and quality improvement initiatives.
Thank you. And we will also add the websites, excuse me, for Alabama's ALPQC, newborn screening program, NAS task force, et cetera, so that people can access that along with seeing what other states are doing. Okay, 2 more questions. They say it's hard to frame, but can you talk about the possible poor infant outcomes that may be caused by structural racism?
Yes, and I just put the latest link I put in the chat is sort of the statement from the CDC director a few months ago of racism as a public health threat, and I think we all recognize that, and I think many of us have recognized it for years. But that CDC director sort of says that very openly and honestly, I think it's sort of propelling us forward to be thinking about how structural racism has led us to where we are today, and sort of the risk factors that we talked about, the contextual factors that we talk about, how so many of them were driven by structural racism that has existed for decades. So I think that is sort of a very accurate assessment, and I think it's something that we want to be addressing.
Thank you. Okay, let's see. There's anyone else? I think we have.
There is one more question in the Q&A.
Someone did respond to that question by SMA, and it says they're hoping to test for SMA by the end of the year. They're working on rule revisions, staffing, et cetera now. Thank you, Mary. And I have another comment that UAB uses an educational bundle from NICU to teach all of our patients, and they are happy to share that. Thank you, audience. You're so helpful. And the other question in the Q&A is about what we're doing on the policy level, and we will get more into that as our day progresses. I know that we'll speak some about, like I said, our own child death review, infant mortality review, maternal mortality review committees, and the things that they're doing to make changes in our state.
And at the national level, there is the Secretary's Advisory Committee on Infant Mortality, which has recently pulled in maternal mortality And on this group, it is a combination of federal members from the CDC and other areas, as well as many public civilians that are taken on as special government employees that have specifically addressed infant mortality and maternal mortality and poor outcomes to the Secretary of HHS. If you would like, I can put a link to that website for people to peruse.
Thank you. We'd appreciate it. Well, thank you again to all of our speakers for those great presentations, the wonderful data that you share. Like I said, it's a tough pill to swallow. It's hard to see that picture, but we have to know where our problems lie in order to implement all these great programs that we have and to provide parents with the resources and to make change. So we thank you and our audience really appreciate it. I keep saying thank you and great information. So thank you to the three of you for preparing those presentations and sharing with us. A round of applause for Dr. Ely and Dr. Gilboa. Okay. We're also pushing the Black Maternal Omnibus of Act of 2021. So they're sharing that in the chat as well. We have so many resources. So I hope our audience, and you can see this chat throughout the day. We will also try to send these resources to our participants at the end of the events to make sure everyone has them. Thank you.
Thank you.
Thanks.
Okay. The next presenter we have is Ms. Stephanie Moody, who is the Health Equity Coordinator at Healthy Birthday, Inc., and she's going to give us a little information about the Count the Kicks Stillbirth Prevention Campaign. Welcome, Stephanie.
Thank you for having me on today.
Thank you for coming.
Am I able to share my screen?
Yes, ma'am.
Perfect. Okay. All right, perfect. Are you able to see my PowerPoint? Or do you see PowerPoint page with notes?
Yes. I see your presentation.
Perfect. All right. Thank you so much. Well, first I want to say thank you for being here with me on today as I share about Count the Kicks, which is our solution to reducing stillbirth outcomes. Now, I'm sure that throughout the day, you're going to hear many staggering statistics regarding stillbirth, maternal mortality and morbidity, but I'm here to share how together we can counteract these statistics and save lives together. I also would like to thank our partner, Alabama Department of Public Health, for this opportunity to be here on today. So my name is Stephanie Moody, and I am the Health Equity Coordinator with Healthy Birthday and Count the Kicks. Here at Healthy Birthday, we have a laser focus on stillbirth prevention, but we also focus on eliminating the racial disparities that exist and persist. As you know by now, I'm sure you do, statistics show that Black women are 2 times more likely to lose their child to stillbirth and 3 to 4 times more likely to die during childbirth. My responsibility is to look at the inequities in birth outcomes in your state, develop strategies to address it. And part of that strategy is to build partnerships with community organizations that serve within the marginalized communities so that we're not only educating expectant parents, but also educating the providers, the doulas, the midwives, home health and maternal health workers. Our goal is to work together with those who are boots on the ground, getting the information in the hands of those who are most impacted by stillbirth. We want to move to a place where race is no longer a predictor of stillbirth. My passion for this work in stillbirth prevention came after finding out about the inequities that persist in stillbirth outcomes in the African American community. My passion for the fight against it actually really began when my sister Angie lost her daughter Jasmine to stillbirth in the early 90s. While we were working on a campaign to educate the faith-based and community leaders in Des Moines, my son and daughter-in-law became pregnant. I asked Courtney if she had heard about the Count the Kicks app, and she used it. On her due date, Court thought that she was in labor, but noticed that Luna wasn't moving as much. Originally, they told her to lay on her left side, drink a lot of water. They even tried in the hospital to give her sugary drinks, which we know is not the right way to go. They need to identify why she's not moving as much instead of trying to force her to move. Court was a first-time mom, and there's times that we can feel a little anxious about giving birth, but Court decided to go into the emergency room anyway. She provided her doctor with information that she had from tracking Luna's movements and was able to prove that Luna was not moving like normal. They examined her. They found out that there were actually 2 health issues that would have prevented our Luna from having a healthy birthday. Since then, I've continued to work to educate, empower expectant parents and maternal health workers on the importance of counting as well as tracking their fetal movements. Saving babies, yes, this is my dream job. I couldn't think of a better way to spend my life. And I'm honored to be able to share, excuse me, this information with you all on today. So just to ensure that we're all on the same page, I always like to start with definitions. You would be surprised at the number of healthcare professionals who are unaware of the difference between stillbirth and infant mortality. Stillbirth is the loss of a baby after 20 weeks of pregnancy. On average, in the US, we lose about 23,500 babies that are born still annually. Now, miscarriage is usually defined as a baby that is lost before the 20th week of pregnancy. Infant mortality is the death of an infant before his or her first birthday. Now, on an average, we're losing about 22,000 infants every year to infant mortality. But notice that stillbirth is slightly higher. So it is just as prevalent as infant mortality, yet no one is talking about it. If you ask expectant parents about the Back to Sleep campaign, about safe sleep, they can tell you what that is. And it's not to speak down about these campaigns by any means, because they are just as necessary if you look at the numbers. They're pretty close. But what I'm trying to get to is that it's really important that we let them know about tracking, counting fetal movements, and they need to be aware of the stillbirth prevention efforts that actually exist. So let's look at the stillbirth by the numbers. We want to look at these rates first, and then nationally, and then we'll actually look at Alabama's data. We are losing 1 in 169 pregnancies to stillbirth. There are big racial disparities that exist. Black moms are losing 1 in every 96 of their babies to stillbirth. Hispanic moms, 1 in 199. Indigenous women, 1 in 138. White moms are losing 1 in 204. Asian Pacific Islanders, 1 in 233. So Black moms are twice as likely to lose their baby to stillbirth when compared to their white peer, friend, or neighbor. Families are 10 times more likely to lose a baby to stillbirth than they are to SIDS. Yet again, no one's talking about it. Let's take a look at Alabama's statistics. The data for Alabama is actually based on the stillbirth data from the Alabama Vital Statistics. My goodness, say that 3 times fast. And we also want to note that fetal deaths do not include abortions. And the US data is from CDC Wonder. This graph actually shows 3 different averages. The red line is Alabama's average. Notice it's way above everything else. Blue is the national average. Yellow is Iowa's average. Notice how Alabama is actually trending above the national average. This is why this summit is so important. In Alabama, we're losing 8.85 babies per 1,000 live births to stillbirth. This means that 1 out of every 113 pregnancies in Alabama actually end in stillbirth. We are losing 527 babies to stillbirth each year. So let's take a look at Iowa's stillbirth data. Here is what it shows for the life of our campaign. The red line at the top represents the national stillbirth rate, and the dots and trend line beneath it is our Iowa rate, which started in 2003 going through 2020. Where the blue dot meets the red line at the top is 2008, the year our campaign actually started. You can see the trend line goes down from there. One important note is that the majority of the US has remained pretty stagnant, whereas Iowa's rate has decreased. Of course, there's been some years that it fluctuates, but it's important to look at data every year and look at it on average. So like a large syphilis outbreak or other factors, outside factors, could cause a spike. So that's very possible. But there are a variety of factors that could lead to an increase or decrease in the state's stillbirth rate. But one important takeaway is in Iowa, with risk factors like smoking or obesity rate, those things continue to increase during this time frame. Our stillbirth rate still saw a steady decline while the rest of the country remained stagnant. This is how we know that our stillbirth prevention efforts actually work. So as mentioned on the previous slide, there's definitely a large divide when it comes to those who are more likely to experience stillbirth. I wanted to take a moment to share what research has shown to be some other contributing factors to the racial disparities in stillbirth outcomes. We want you to definitely note that Healthy Birthday Inc. has reviewed research articles, and these points came from various articles, and we'd be happy to share them with you if you are interested. So you might wonder, why is there such a large disparity when it comes to stillbirth with African American women in comparison to white women? Research shows that there are a lot of contributing factors to the racial health disparities in stillbirth. Research points to the following causes for the disparities that exist and persist in stillbirth outcomes for Black women. I say exist and persist because as long as we're pretending that they're not there, they're going to continue to exist and persist. Systemic racism, when policies, practices, representations, and norms work together to perpetuate racial inequity. Some examples include higher infant mortality rates, less school funding, harsher punishments for crimes, less income. Toxic stress. Research shows that years of being treated unequally and or unfairly, essentially being an African American woman in a systemically unjust society and all that comes with it, have led to real and pervasive health issues for Black women. Epigenetics. Those are the physiological variations that are caused by external or environmental factors that switch your genes on and off, and it affects how cells read the genes instead of being caused by changes in the DNA sequence. Predispositions to certain conditions that may lead to stillbirth, like gestational diabetes, preeclampsia, or high blood pressure, which are all linked to maternal stress. Experts say Black women are less likely than other races to receive early treatment for these conditions. Access to healthcare, socioeconomic barriers, all of these things play into the racial disparities that exist. Research also shows that education is not a determining factor. A college-educated Black woman is still more likely to lose her baby to stillbirth than a high school-educated white woman. We've got to do something about it. So what is Count the Kicks doing to research and reduce these disparities in stillbirth? Well, one of the things that we did is we hired a health equity coordinator, which is me. So I'm on staff. My purpose is to ensure we're looking with that equity lens with everything that we do. So I want to make sure that I look at the inequities in the birth outcomes in the states that we partner with and develop strategies to address the inequities that persist. And again, part of that strategy is building partnerships with community organizations that serve within those marginalized communities so that we're not only educating the expectant parents, we don't want all the weight on them. We want to also make sure that we're getting to those who work with them. Those are going to be the doulas, the midwives, home health and maternal health workers. We want to get together with those who are the boots on the ground. getting that information into their hands so that they can get the information into the hands of those who are most impacted by stillbirth. We want to move to a place where race is no longer a predictor of stillbirth outcomes. We are constantly looking for funding opportunities to reduce racial disparities that persist in stillbirth. One of the ways that we utilize our funding is we work to translate our app and our brochures to meet the needs of those who don't speak English. So if your area has a high concentration of maybe Haitian or Burmese or Hispanic, we always make sure that we work with the different organizations who would be able to help us to fund that so that those translations are available to them and they are able to actually get the information in their hands in a way that they can actually understand it. We are also an inclusive organization with 100% board and staff training on anti-oppression and structural racism. We work within the marginalized communities by improving our programming based on the lived experiences that are shared with us by women of color. As we learn more about the issues, we identify solutions and we work with our partners on implementation. Our app is in 12 languages. It's culturally appropriate. We make sure our educational materials can reach the culture that we're going after. And we even have low literacy brochures that are more picture-based for those who have trouble with reading. We also have created videos featuring women of color so that those who are viewing them are able to connect with the face that they see, as well as updated. And we've printed our educational materials and frequently asked questions in multiple languages. So what is Healthy Birthday and Count the Kicks? Now that we've looked at the statistical data about and surrounding stillbirth. Healthy Birthday is our nonprofit organization that is the headquarters of our Count the Kicks campaign. It was founded by 5 Iowa moms who all lost their babies in the early 2000s to stillbirth or infant mortality. In 2004, they worked with the Iowa legislature to create Iowa's stillbirth registry to begin collecting data around stillbirth. A few years later, they attended a public health conference in Norway where the doctors talked about seeing a 30% reduction in stillbirth by teaching pregnant women how to monitor their fetal movement during the 3rd trimester of pregnancy by doing kick counting sessions on a daily basis and recording them. So we didn't create kick counting, but what we did is we created the tools to help parents be able to do it and keep track of it. So after this conference, they came back inspired by the research and they birthed Count the Kicks. So Count the Kicks is our evidence-based stillbirth prevention public health awareness campaign that is for expectant parents in the 3rd trimester. We created an app that has a non-invasive way to track babies' fetal movement in the 3rd trimester. We want them to start at 28 weeks for a normal pregnancy, 26 for high-risk pregnancies. Research shows a change in baby's movement or reduced fetal movement can sometimes be the earliest or the only indication that a baby may be in distress and needs to be checked by a healthcare provider. By counting and tracking your baby's kicks, jabs, and rolls, you can get to know what is normal for your baby and which can alert you to any potential red flags that you may have. Now, I'm sure that everybody on here would agree that stillbirth is not a topic that everybody is just all excited to talk about. You're not at the family picnic sharing about it. This is why you'll notice when you look at our materials, they are fun, they are bright, they are colorful, they are empowering. This is exactly what the founders wanted. It's mom focused, educating expectant parents on the importance of tracking fetal movement. You're able to complete your kick counting session on our free mobile app, or we have paper charts for those who struggle with internet capability or accessibility or don't have access to a mobile device. Our app empowers moms to speak up and share with their providers if they notice there's reduced fetal movement. It also provides them with the data to back up why they are concerned versus just trying to explain why they feel something is wrong. Excuse me, it is allergy time for me. This is exactly what my daughter-in-law did with our Luna, and she is here today. She is safe. She is sassy as all get out, and she is well, and also now a big sister. So let's take a look at our app. Someone might be wondering, how does this work? How would I instruct someone on how to count their kicks? Well, I'm glad you asked. So Count the Kicks is an easy, free, reliable way to count your baby's kicks daily in the third trimester of pregnancy. Starting at 28 weeks or 26 if you're high risk or pregnant with multiples, you want to begin counting. So what you want to do is you want to tell moms, get comfortable, sit with their feet up, and they want to do this at a time where baby is most active. You can count everything from kicks, rolls, jabs, anything except for hiccups, because hiccups are involuntary. Instruct them to count their baby's movements every day, preferably at the same time. The app is going to tell them how long it takes for their baby to get to 10 movements. After a few days, you're going to begin to see the average length of time that it takes to get to 10 movements. If you notice a significant change on how long it takes to get to 10 movements, then you want to alert your doctor right away. Someone might be wondering, what would be considered a significant change? If it usually takes your baby 15 to 20 minutes and all of a sudden it starts taking an hour to an hour and a half, it's definitely time to notify your doctor and let them determine what the next steps are going to be. Our app is again available in 12 languages. It works on both Apple and Android products. If they get interrupted during the session, maybe they're potty training or potty training a sibling, or they receive a phone call, somebody knocks at the door, they can simply hit restart and begin their kick counting session again. You also have the capability to delete a kick if you accidentally track one. In the world that we live in today, we are all extremely busy, and it's real easy to forget. So if moms are anything like I was when I was pregnant, pregnancy brain is definitely a real thing. Our app allows you to set a daily reminder that's going to help you to remember to count those kicks. After a few days, they're going to begin to see a pattern for their baby or their babies if they're tracking multiples. And they'll see the average time that it takes for their baby. Again, I can't stress that enough. Every baby is different, so they need to know the average time it takes for their baby to get to 10 kicks or 10 movements. They can also review their kick counting history. It can be downloaded to share with their provider, and they can discuss it at their OB appointments. Now, if they see a huge decrease or increase in how long it takes, then they want to go into their doctor. They don't want to wait until their appointment. Our app also tracks future pregnancies so that you don't have to create a new account with every pregnancy. They can manage their account on multiple devices, including the Apple smartwatch. So if you're downstairs and you left your phone upstairs, but you've got your watch on, you can count on the watch. And then when you're back upstairs, you can use your other mobile devices. Remember, if your client does not have access to a mobile device, or if they live in a rural community where internet is not easily accessible, on our website, they can download our kick counting chart, and that's going to assist them in tracking those movements with pen and paper. We call it Counting Kicks Old School. So we also have a new strength tracking feature. Research shows that expectant parents should also be paying attention to the strength of their baby's movements while counting and tracking their kicks. So with our new strength tracking feature, at the end of each kick counting session, you'll be asked to rate the strength of your baby's movements. If your baby's movements become weaker, it can be a sign that your baby needs to be evaluated. This new feature teaches us how to judge the strength of the baby's movement. You can rate your session from fluttery to fierce. Fluttery are going to be the light movements that are hard to see from the outside, similar to what is felt when you first started feeling baby move. Fierce is going to be the strong movements where you can visibly see the baby moving around inside. It can feel like a limb is literally trying to poke out of your belly. I've had that, and my goodness, it's something else. Simply rate the strength of your kick counting session by selecting fluttery, which is indicated by 1 footprint, up to fierce, which is 5 footprints. You can include a note detailing how the session went and what you may have noticed during the session. This note just says, baby felt strong like normal. Once you finalize the session, you'll see a graph showing your strength average as well as the average time it takes for your baby to get to 10 kicks. If you notice a significant increase in your average time, where it's taking baby longer to get to 10, or a decrease in the strength of your baby's movements, contact your provider. Reduction in fetal movement can also signal anything from low amniotic fluid or ruptured amniotic sacs or a tangled umbilical cord. If your provider's office is closed, the hospitals are open 24/7, ready to serve. The risk of not speaking up outweigh the risk of going in. So by talking about monitoring fetal movements and teaching parents how to do it in the third trimester, we have the opportunity to do something about the stillbirth rates in Alabama. Decreased fetal movement can indicate a need for more evaluation and has the potential to save lives. There is no cost to the client for use of the free app, and research shows there are benefits to doing it, including reduction of preterm birth rate, fetal growth restrictions are identified earlier. It is also a way to promote family bonding. Get dad and siblings involved in counting to promote bonding before baby gets here. We also know that women who have stillbirths are at a substantially higher risk for severe maternal morbidity than women who have live births, regardless of the cause of the fetal death. Counting kicks is an early warning system that reduces the chances of stillbirth by knowing when normal changes for baby and contacting the OB midwife, or even going into the ER if it's after hours. If they don't feel like they're being heard, tell them, go in and get them monitored. For those who are with us today that enjoy looking at research, please feel free to go to www.countthekicks.org, and there are many research articles and testimonials from experts who support kick counting. So the question becomes, what do we do now? One thing you can do is download the app, practice, practice, practice. Make sure that you share the information with the team of people that you work with, any pregnant person that you come into contact with. You can order our materials for free thanks to our partnership with the Alabama Department of Health. And you can even designate someone in your office to oversee ordering materials. When things get low, go back and order more. It's free shipping. We also have a CE training that is worth 1.5 credits that you can take, and that information is also on our website. I want to end today with showing you exactly why we do this. We do this because of the mamas and the babies that are dying. We have a real opportunity to make a significant change in maternal health and care, and it starts in our very own backyard. Part of our outreach and education comes from our mom-to-mom sharing. And if you go to www.countthekicks.org, you'll find over 70 stories like the one I'm about to show you. This story is about baby Nala, whose mom saved her when she used our free app, and noticed that Nala was not moving. Let's take a quick look.
Stephanie, we're not hearing audio.
Uh-oh, I'm sorry. When I shared, I'm going to stop it. I apologize. When I shared my screen, I needed to actually share my sound, and I did not. I am over my time. Is it okay to share it, or should I stop?
No, you have time. Go ahead.
Okay, just a second. I'm going to reshare my screen. Forgive me for that. Okay. All right. Let's try this again.
She came back in after she had me put on the monitor and stuff, and she's like, we're just gonna take.
That's great. We hear it now.
Perfect. Okay.
Had me put on the monitor. She came back in after she had me put on the monitor and stuff, and she's like, we're just gonna take her. And I'm like, what? And she's like, her heart rate is dropping every time you have a contraction. I was already scared, because I was a high-risk pregnancy. So I basically learned from the doctor's office, the little yellow sign that was right there. When she started moving, I was very alert with her movements, That was what I lived for, just because I wanted her to, her to make it and survive. When she started moving, she moved, and she was consistent. It was always at a certain time. Nala was a kicker. When she started kicking, she was kicking. And this day, she wasn't moving at all. I started drinking cold water. I was drinking so much, my stomach was hurting to make her move. And she didn't move at all for me at all that time. So I'm just like, okay, I'm gonna get her checked out. It was the heart rate that was dropping. Like they said, her heart rate would drop real low every time I would have a contraction, and they were like back to back. She thought that it would save the baby, so she pulled her out. She was like, it's a good thing you came when you did, you know what I'm saying? Because if you wouldn't have, we probably wouldn't be having the same outcome. I think about it every day, like, oh man, what if? Definitely to pay attention to count the kicks, I feel like it's important just because had I not, knew to do that, Nala wouldn't be here. Don't second guess yourself. Don't feel bad or stupid. Don't worry about insurance or the emergency room bill. Go check on your baby, because your baby might not be here. You just pay attention, seriously, like it's your baby's life.
I absolutely love that video. I get tears because this is why we do what we do. These are the stories that we hear day after day that let us know that what we're doing is effective. In Iowa, since the inception of our campaign, we saw a 32% reduction in the amount of stillbirths that were taking place. For Black women, we saw a 39% decrease. So we know what we do is worth our time. It's worth the effort. It's worth the energy. That is why we value the partnerships that we actually have. And so that is the end of my presentation. I want to thank you all for being with me on today and for allowing me to share our solution to stillbirth prevention. And if you have any questions, please feel free to reach out to me. My information is on our website. It's www.counttthekicks.org. We are willing to come and to train your staff and to do whatever it takes to help save these lives. Thank you so much, everyone, and have a great day.
Hold on, Stephanie. We do have a couple questions.
Go ahead.
So I want to tell everyone that we did put the Count the Kicks web address in the chat box so that you can access that, as well as the web addresses for the perinatal program, the Women's Health Division, and just general ADPH. We'll continue to add those throughout the day. Okay, Stephanie, I have a couple questions for you. The first one is someone was asking, could the app be done in Korean? There's a large Korean population in Montgomery. And this is just a general question because we saw that you had a list of languages. How are they chosen and how often do you add new languages?
So they're chosen based on the area, more or less. So when we partner with the different MCOs or Department of Public Health, as we partner with them, they actually help to pay for those things. Mm-hmm. So if there's a large population, we would go back to whoever our partners are in that area and say, we're able to make impact by making this translation. This is what we would need. Are you able to fund us? This is why, again, our partnerships are critical. And also the data is critical. So by being able to show that we do literally reduce the stillbirth rate through this campaign, it helps them to understand why it's important to put their money towards it.
And we did purchase, the Alabama Department of Public Health purchased materials that are free to download for our providers and other people in our community that want to. And when we get questions and requests, we do pass them along to the County Kids program so that we can provide the resources that our communities need. The other question was regarding, it was a legal question. The comment was that Count the Kicks looks like a wonderful resource, but it is a third-party app. What are the legal risks to providers who recommend it to mothers?
I'm not an attorney. So let me start off by saying that I am not an attorney. However, I don't believe that there are any legal risks. And the reason why is this. They are using the data from the app. It would be the provider's responsibility after that to determine based on, so you would probably consider the mother's age, the mother's health prior to getting pregnant. If they're high risk, you would go from there to determine what your next steps would be as far as what tests you would do and things of that nature, whether they want to do stress tests or whatever it is, monitor the baby. They need to figure out what's going on. So by providing that data, all that is an assistant to you. It's just going to let you know something's taking place in utero. And then it is the doctor's responsibility to be able to say, hey, let's do this test, let's do that test. So I don't see any legal ramifications just by implementing it. It's just an assistant, a tool to help mom to feel more comfortable. One of the misconceptions with a lot of doctors that we hear, and there are several who back us, but then there's the few that'll say, it'll give them anxiety. Through our research, we do, at the end of their pregnancy, we do a survey. Mm-hmm. We ask them flat out, did this make you feel more anxious by counting kicks? And the answer is no. It actually reduces the anxiety because they're no longer going off of a feeling. Sure. My sister went in the early 90s with no Count the Kicks app with a feeling that something was wrong. This was baby number 5 for her. And all she could say is, I feel like something is wrong. She couldn't give them any statistical data. There was nothing that she could say that she knew something was wrong. My daughter-in-law, fast forward to 2019, fast forward to 2019, she had those kick counting sessions. That doctor looked at it because at first they were telling her the same thing, drink water. What do you think that did for me? That created a lot of anxiety because it took me back to the early 90s with my sister. And so they told her drink water. They told her to, lay on her left side and all these other things. What it ended up doing, she was able to provide them with that information and say, look, I need you to see this. And when they saw that Luna was not kicking as much, they could see that there was definitely an increase in the time that it took to get to 10 movements. They started running different tests and Luna was born emergency C-section about 2:00 the next morning.
Thank you. Okay, one final question before we move to our next panel. As a public health educator in Alabama, how do you think I could relay the message about stillbirths and reinforce stillbirth prevention methods such as the app to the underserved population, especially those at greater risk? Their comment is that, as you mentioned, this is a very sensitive topic because no one wants to think about that happening to them, but reducing the stigma about stillbirth is very important, and they'd like to emphasize the topic more when doing community outreach.
So we did that. I actually was this is how I got connected with Count the Kicks. I am also a local pastor. And so what we did was we teamed up with Count the Kicks because we found out about the stillbirth, the disparities that exist, the inequities in birth outcomes. And so what we did is we teamed up with the community leaders to help them to learn and know how to talk about it. The awesome part about it is our brochure does the majority of the work for you. You don't have to necessarily talk about the statistics with the clients that you serve. But what we did do is we just told them this is a great way to bond with baby, to know what's going on with baby, because nobody wants to talk about it. It's not fun. There's nothing fun about it. But if you look at our materials, they're bright, they're colorful. and it's empowering. So you're literally empowering them to become their own advocate. A lot of times, from the focus groups that we have done, we're hearing, and I believe that there's research on this as well, but I don't have any to cite at this minute. They said that Black women don't feel like they're heard. This empowers them to be able to speak up. So what this does, it gives them exactly what is necessary to say, hey, this is what I have. Can you talk with me about this? What do you think about the fact that it was 15 minutes here and now it's taking an hour? What should I do next? So you're literally empowering them to become their own advocate, as well as, like I shared earlier, helping with that bonding time. A lot of people wait to bond with baby when baby gets here. So siblings don't get to really be a part of the pregnancy. Dad, mom's carrying baby. She's a part of the pregnancy. She is the pregnancy, right? So by being able to give them count the kicks, you can involve the rest of the family. You can share the kick counting sessions with family members and let them know how baby's doing, how active baby has been. It just gets everyone to be a part of it. So that's a way to talk with them about it and to get rid of the stigma of talking about stillbirth. Turn it into a positive, because it's just like an early warning system. No one wants to talk about a house burning down, but we'll talk about the smoke detectors. Think of the Count the Kicks app as a smoke detector.
Okay.
It just helps them to be alerted if something's going on.
Thank you.
You're
One
welcome.
quick question. Is the app is it cloud-based or is it using phone memory?
It's actually cloud-based. That's
Okay.
why you're able to use multiple devices for the same account. So you can count on your Apple Watch, you can count on your iPhone. Now, it is going to take up space when you download it onto your phone, but your statistics, your data is cloud-based.
Thank you, Stephanie. Excellent job. Thank you. They're saying that video is very effective, conveying that very important message. Other comments were that they like how this app empowers pregnant folks to advocate for themselves and their babies. They love the stories, very effective. And then some people are saying they are using the cards on their unit. They're giving them in when they come in for a decreased FM. And Birthwell Partners teaches about this app to their doula trainees and encourages them to use it. They've ordered the brochure. So the word is spreading in Alabama. We are
love it. I love it. I can't wait to see that bar graph go down the same way that Iowa did. And that it just makes it all worth the long nights, the long days, and all of the teaching and trainings from one place to another, and makes it worth it to see those numbers decrease.
Thank you, Stephanie, for that great presentation.
Thank you so much for having me today.
Okay, and before we go on, I keep seeing questions about the presentations, and we will verify with all of our presenters about the slides that they are able to share. I know some of them had to get prior approval, so we'll just make sure that those are cleared to share with the public, and we will either put them, attach them to this presentation or send them out after the summit ends. Okay, our next presentation is a panel discussion, and it's titled "The Community Response to Infant Mortality: How Community-Based Organizations Can Improve Birth Outcomes by Supporting Mothers, Fathers, and Infants." Totally relating to what Stephanie was saying about involving the family. We know how important it is to have the entire family involved in the health of moms and babies. There's a lot of efforts going on to bring in fathers and other people to support them. So we will have our Community Response to Infant Mortality panel, which will be moderated by Dr. Regina Traylor, the Executive Director of the Gift of Life Foundation. Thank you.
Thank you. Hello, everyone. As mentioned, I'm Regina Traylor, Executive Director for the Gift of Life Foundation, and I will be the facilitator and a panelist today for the Support for Mothers, Fathers, and Babies panel. We're really excited to have you join us on today. So this time, what I want to do is introduce our panelists. So we have Mr. Ricky Green, CEO and Project Director for the Birmingham, Alabama Healthy Start Plus. We have Dr. LaLanta Bradley, Assistant Professor in the College of Community Health Sciences and former chair of the Tuscaloosa Stork's Nest. We also have Ms. Honor McDaniel, Director of Maternal and Infant Health at March of Dimes, and Mr. Akeem Johnson, a recent graduate of the Healthy Start Father in Action program at the Gift of Life Foundation in Montgomery, Alabama. So thank you for joining us today. So during the next hour, what we want to do is focus on offering you an overview of the agencies, identify how each agency or program impacts birth outcomes, and address local partners who support their mission. We also want to address programs for fathers and their impact on birth outcomes. So let's get started. Ms. McDaniel, can you tell us briefly about the March of Dimes and some of the programs that you currently offer?
Yeah, absolutely. Thank you so much for having me today. I'm excited to have this discussion. So March of Dimes is a national nonprofit, but we have local offices that get to focus directly on the health of the state that we're in. So I'm specifically in Alabama, focusing on Alabama health. And we as an organization started under President Roosevelt with the goal of eradicating polio. So I know a lot of people remember the polio shot that they got, collecting those dimes at school and putting them in a little flip book. And we were able to eradicate polio with a researcher who came up with a vaccine. And now we have been able to shift our focus to the moms and babies of the country and the threats against them. And we believe that every baby deserves the best possible start to life, no matter their mother's age, their socioeconomic background, or their demographics. So after polio, we focused on folic acid, newborn screening, and other therapies that would help a baby start and have a great start to life. We eventually shifted to infant mortality, and we specifically look at preterm birth as that's the #1 preventable cause of deaths of babies in the United States.
Okay.
So March of Dimes, actually, we have a 3-pronged approach using research and data, advocacy, and mobilization efforts, and then direct impact. So in Alabama specifically, we work with partners around the state to address issues very specific to Alabama. And we do that through legislative issues such as Medicaid expansion or programs using the Perinatal Quality Collaborative. We also have our group prenatal care program. And we even do professional development like our implicit bias training in maternity care. And we do that in partnership with others. We never do anything alone. So we definitely have our partners there helping us create these programs or working towards Medicaid expansion, working towards anything that we think Alabama needs to help push us forward.
Yeah, awesome. Thank you so much. Dr. Bradley, can you tell us a little bit about the Tuscaloosa Stork Nest?
Yes. So the Tuscaloosa Stork Nest is part of a national initiative with the sorority Zeta Phi Beta Soror. And it's an incentive-based prenatal health promotion program for low-income pregnant women. But I would say, all women are have equal access to the program. We have a partnership with, and speaking of partnerships with March of Dimes, we have over a 40-year history of working with the March of Dimes. And this is actually a jointly owned trademark effort between the two organizations. Stork's Nest encourages women to make and keep prenatal care appointments and participate in prenatal education classes. So we offer incentives if you complete those 2 goals. And we have local Stork's Nests across the state of Alabama. And at those Stork's Nests, the women who participate in the program can shop using points that they've collected to get certain baby items. So it could be bottles, it could be diapers, wipes, clothing, that kind of thing. Because of COVID, we have transitioned to a virtual model, and I would be more than welcome to talk a little bit more specifically about that later on in our talk. But in addition to being the former chair of the Stork's Nest, I'm also an assistant professor in the Department of Community Medicine and Population Health. And one of the research items that I focus on is maternal and infant mortality. And so I've done some work on the TERM project which is telemedicine towards empowering rural moms. And I'm currently working on a doula, establishing a doula program in the Black Belt to address some of the health disparities in that region.
Awesome. Yeah, we'd love to hear a little bit more about that. Thank you so much.
Mhm.
I'll just take an opportunity, as I noted earlier on, I'm facilitating, but I'm also one of the panel speakers today. So what I'd like to do is just briefly touch upon the Gift of Life Foundation and an overview about what we do. So we are certainly committed to improving the health and well-being of at-risk mothers and babies to build a stronger community. We do this by offering home visitation services to expecting and parenting women, children, and men. So we have 4 different home visiting programs, and I'll try to highlight those briefly. We have Nurse Family Partnership, which is staffed by registered nurses. All of these programs are voluntary, so this is a voluntary home visiting program for first-time moms who are pregnant at 28 weeks or less in the Montgomery, Macon, Russell, and Autauga County. And they can see the clients up to 2 to 2.5 years. We also have Parents as Teachers, which is staffed by social workers or social services staff. It is also an evidence-based home visitation program that provides services for pregnant women and families at high risk for infant mortality. And we provide support, resources, and skills that they need to become effective parents. We want to increase self-sufficiency and encourage emotional, social, and physical well-being for the baby and the family. We do provide care with this program prenatally through the child's age of being up to 2 years old. We have mobile family coaching. It's one of our innovative programs that uses the evidence-based curriculum called Parents as Teachers. And what we do is use that to educate our parenting moms and caregivers through a combination of supportive messages related to texting, videos, social media, phone calls, and face-to-face visits. And of course, like I mentioned before with COVID-19, we are utilizing telehealth quite a bit right now, but certainly look at transitioning back. We also have a Parenting Forward program, which is staffed by social workers. And this program gives teen moms and dads enrolled in area schools the education and support and connection to community resources that they need to become effective parents and plan for a successful future. And lastly, but certainly not least, we have a Fathers in Action program. And this initiative seeks to increase the number of children served through Gift of Life programs with involved fathers. So the initiative also promotes responsible fatherhood throughout the community. And they utilize a curriculum, evidence-based curriculum called 24/7 Dad. So those are just a couple of the programs that we have in place now. Mr. Green, we would love to hear a little bit about the Birmingham Healthy Start Plus program.
Sure, I would be glad to share. I will begin by giving a brief overview of Birmingham Healthy Start Plus. Birmingham Healthy Start Plus Inc., the organization, as well as the program. Birmingham Healthy Start Plus Inc. is a 501c3 nonprofit organization based in Birmingham, Alabama. That organization actually is built on the existing, what was the existing, and still is the existing federal Healthy Start program funded in 1991. Originally, the federal Healthy Start program was for our area was referred to as Birmingham Healthy Start. And that was because at that time it only served individuals residing in the program area, which was targeted Birmingham communities. And in 2012, we expanded the service areas to the cities of Bessemer and Fairfield, and which is now why we call ourselves Birmingham Healthy Start Plus, as opposed to just changing the name. And at that time, when we expanded to Bessemer and Fairfield, we actually had inherited another Healthy Start grant that included those areas. And when we applied in 2014, we could only have one, so we combined everything. Our mission statement would include providing a service delivery system that engages and empowers, as well as educates the community about providing positive behavior for health outcome. Services are provided through a personal touch, trauma-informed care service delivery model. That's as several of our members recently, well, last year, completed an 8-month training process in order to advance Birmingham Healthy Start Plus and been recognized as a trauma-informed care agency organization.
Mhm.
When we talk about the purpose of Birmingham Healthy Start Plus, the program, we see that it is to improve health outcomes before, during, and after pregnancy, mostly for African American women, who are the primary individuals that we serve in our population, as they are the ones that have the worst outcome. But anyone residing in that area, in our targeted areas, our service areas, are eligible to participate in the program. We want to reduce the infant death and other adverse outcome among women giving birth that live in our areas. We want to address and help reduce disparities in perinatal health and to promote father inclusion and father engagement. We have an array of services that are provided. Many of them are similar to what has already been mentioned, but I would just like to just name a few, and that is comprehensive home visiting services, which includes the comprehensive trauma-informed care perinatal screenings. We have case management and support services to both the mothers and the fathers. We provide an array of education classes, and that would include parenting and childbirth, as well as safe sleep. Now, with our education classes, we are offering them two ways, and they're both kind of, you might say they're virtually, but one of them is with an archive of classes that our health educator, Ms. Cynthia Ward, has already prepared. So at any time, if that, provided that the client gets the link, they can go in and watch those classes. But also we have virtual classes where they're live. I mean, they're virtual, but she's actually doing them at that time and has the capacity to entertain questions, comments, concerns during, actually during that time. We were one of the Help Start programs who were grantees who were awarded funds for enhanced clinical services. And for us, our focus was on mental and behavioral health. And that's another big thing that we're doing since 2019 is providing that services. We don't have to have be concerned about a long waiting list for clients who are needing those services, because we actually provide them through contractual provision.
Okay.
And as I mentioned, we do have a fatherhood component, and as we all know, I mean, that has just been a crucial. And I think that was another part that we have to respond to, and I would talk about the impact on that. But even then, I won't go into that much detail, because the best person who can talk about the importance of a father, that father component, would be a father himself. And I will let Ms. Taylor at the appropriate time, introduce that individual. So I won't go into that much detail, but I will want to mention that we do have a fatherhood component, and that has been something that we've been striving to have since 1997. We finally got there.
Absolutely. Thank you so much, Mr. Green. I think actually that's a great segue to Mr. Johnson. So Mr. Johnson, we touched upon briefly programs for fathers, but it would be really nice to hear from you to tell us why you wanted to participate in a program for expecting or parenting fathers.
Okay, good morning, everyone. I would say the reason I want to participate is because I was becoming a new dad, so I didn't know what to expect. And I think the biggest thing is that as a personal life story, I didn't have a role model in the home, to really, okay, as a father figure, okay, this is what I'm supposed to do. This is how to prepare for a child or a sibling, because I have two younger siblings. So, I had my brother, but as far as the program, it was accessible. It was very accessible. So I felt it was important to get in that so I could learn from this step by step every step of the way, because I have my brother who's a father, but he's in Birmingham, and the fatherhood program was here locally in Montgomery, and it was somebody I could meet with and I could communicate with on things if I have any questions on what to do, what not to do, how I go about doing this. That's why I felt like it was important for me, because it was a jump start to becoming a father. It helped me along the way on raising my daughter.
Absolutely. Thank you. So I think, we're talking about birth outcomes today, and I think this is one of the key pieces we need to talk about, the fathers in that role. And we're definitely going to come back to you, Mr. Johnson, and talk a little bit more about that. Thanks to each of you for your comments so far. So again, we've heard a brief overview of what your programs offer. Ms. McDaniel, can you talk to us a little about how the March of Dimes community programs impact birth outcomes?
Yeah, we at March of Dimes, really, when we're looking at Alabama, we want to focus on upstream issues that affect birth outcomes. So we start with infant mortality and we say, why do we have high rates of infant mortality in Alabama? Well, we have high rates because of preterm birth, because of birth defects. So why do we have high rates of preterm birth and birth defects? Well, because of X, Y, and Z. So we continue to ask those why questions. We call it our why chart. We're asking why multiple times until we can break it down to get to that root cause. So a lot of the time we're working on legislation that actually affects more than just infant mortality, like Medicaid expansion, because we're looking at things that when you start asking about why do we have infant mortality, we're finding out women don't have a car to go to their prenatal care appointment. So they don't get the information they need, or they don't have a safe, healthy walking path so that they can keep their blood pressure down. And so we start looking at generational economic instability, whether our communities are safe so that mother can go or go on a walk, and how far do they have to travel to get their prenatal care. So they look like the things we look at don't look like they're directly related to infant mortality, but when you really look at why a woman has hypertension, you see she doesn't have a place to walk or a doctor close by. So we work with our partners and we try to make an impact a little bit earlier on, maybe even before conception. So we have information and pamphlets and brochures, but also videos, and we have a blog called News Moms Need to Know, where they can go and look. We had a campaign called Becoming a Mom, and we have the counterpart Becoming a Dad, where people have kind of a self-paced informational handouts that they can go through. And we also offer a group prenatal care program that can be implemented to provide prenatal visits and education to a group of pregnant individuals, as well as foster this health literacy, health equity, and it's unique in that it addresses both social determinants of health as well as medical factors. And we created this program with the input of our partners, so that we're not just addressing an existing issue, but we're just not doing it alone. And it's amazing to have partners that we can talk with and pivot, because we've worked with Zeta Phi Beta for 40 years, and we get to help with Stork Snacks, which is this incredible promotion program for low income pregnant women. And while we get to be part of that program and promote it, Zeta is doing an incredible job of raising awareness around prematurity. So really, our programs are all about that collaboration and looking at birth outcomes and thinking, okay, where can we start those building blocks that then affect this woman as she continues through her pregnancy, but then even after pregnancy, so that, as the baby's growing in their first year of life, like, do they have a way for the dad to take the baby on a walk, and so that they're getting out and getting sunshine? Do they have a safe environment for the baby to sleep? Do they feel safe in their neighborhood? So are they having conversations with the people who are going to be looking after baby, not just mom? So are the dads being included in this conversation? Are grandparents being included in the conversations?
Yes.
So I know that Dr. Bradley can talk a little bit more about Stork's Nest, but we just have amazing partnerships that we get to pour into, and that's kind of how we affect birth outcomes, is through a group effort.
Right. One of the things is someone kind of chatted about earlier, and you had a response to, which I would love to touch upon, is the advocacy piece. And I think you kind of put something in the chat about the Black Maternal Mommy Bus Act of 2021. Can you talk to us a little bit about that and any other advocacy efforts?
Yeah, absolutely. So the 2021 Black Maternal Omnibus Act is 12 different bills at a federal level that affects women's health. And so that's going to be something to the effect of research and data. We're going to get money for research and data. It's going to be, so there's one that supports our veterans who are pregnant. And so the link I posted will have all 12 of those bills to look through. But on a state level, we really work with partners, and that can be the Association of, or the Alabama Association of Pediatrics. It can be the Medical Association in the state of Alabama, on pushing forward legislation that really helps and prevents. So that might be Medicaid expansion that we're really trying to push, because a mother loses her Medicaid 6 weeks after birth. Well, if she needs something after 6 weeks, we all know that the side effects of pregnancy don't stop at 6 weeks.
Right.
And she's less likely to take her baby into the doctor if she doesn't have Medicaid, even if the baby does. And, we're pushing that forward, and we're talking to legislators, we're having those conversations. But we're also doing things like talking about what are our laws around workplace accommodations, and our chemical endangerment law. So what can we do to have a diversion programs for women, so that when they're pregnant and have the disease of being addicted to substance use, they have more support in that. And educating those legislators. So we have a lobbying day that we do in Montgomery, where we get to sit down and talk with legislators about maternal health and maternal and child health within the state and what that looks like. So a lot of it is that conversation with those legislators. Legislators want to help moms and babies. They love the moms and babies of Alabama. What it comes down to is educating them on how that's going to affect not only the moms and babies, but the family unit and those outside of the immediate family unit. So we don't have the same regulations as some other entities within the state, and so we can lobby, we can go, we can talk, we can really set forth an agenda and say these are what's important. And so that's what we're doing, along with many other partners within the state, and we're coordinating that so that they're not just hearing it once, they're hearing it multiple times, and they're hearing the same names like over and over again, like March of Dimes and AAP and the Medical Association are all asking you to do this. And it's like, those are a lot of people, and that's a lot of people who have knowledge on that subject. So
right. Excellent. Thank you so much. So I will quickly, from the perspective of Gift of Life Foundation, I don't want to be redundant, certainly with things that have been stated, but some of the things that we do in terms of focusing on improving the birth outcome, certainly we're doing it through home visitation services. So we really encourage prenatal care with the hopes of, catching malformations early, referring the clients to resources such as smoking cessation programs or oral health programs, programs on breastfeeding and so forth. We're certainly encouraging early on, before the baby even arrives, good, safe sleep practices, and also providing those families with supplies such as a pack and play or cribs to continue to support the practice. As I mentioned, we teach good oral health, which is very important during pregnancy. We assist with acquiring transportation for them so that they can access care, because we all know that can certainly be a challenge for many of our clients, just getting to those prenatal appointments. We assist with establishing health insurance. That's very important. We provide screenings related to depression, anxiety, which can also contribute. And we really have a heavy emphasis on enrolling the fathers of the individuals, the moms that are enrolled in our program. The research has shown that the fathers may reduce the stress for that mom during that time, as well as decrease anxiety. And another statistic has shown that the likelihood of breastfeeding increases when they have that support person there kind of cheering them on, because that's not an easy task, but we also know that breastfeeding is really awesome for that child to have. So those are just a few of the things that we do, we believe impacts the outcome of that child. Mr. Green, what role has the Healthy Start Plus program played in impacting your community in regards to birth outcomes?
Well, let me start by saying the national federally funded Federal Healthy Start Initiative will be celebrating 30 years this year. Mm-hmm. And so with Birmingham Healthy Start Plus, as we were one of the original programs. What I didn't mention earlier is that we the agency itself, Birmingham Healthy Start Plus Inc., hasn't been around for 30 years, but the program has, and we just been up under different agencies. But we started up under the Jefferson County Department of Health in 1991. That was the first home for Birmingham Healthy Start. And one of the meaningful impacts, I think, was what we came about during those first very, very, very difficult early years. And the reason why I say that is because that was the time when an agency like the health department had to really show and demonstrate and learn how to work in collaborative with community-based organizations. Well, they really had vital input and was really actively involved. That was something new for the health department. And we played a vital role because we were right there on the forefront, and we took, a lot to kind of like bridge that gap, and it happened, but it took time. That was one of the most impactful things, I think. After that time, we saw a lot of things that occurred with even the health department going through a series of guest relation type of training based on some of the surveys and information that we would get from consumers, participants, and share the information to the leadership of the health department. So that was one of the main things. And we left the health department in 2009 and became a part of, it was at that time Birmingham Healthcare, but it's now Alabama Regional Medical Services. And we were there for 5 years. And it was after the end of that grant cycle is when we branched out independently. But even there, although that was a federally qualified health center, a major role was to show the really meaning, what does it really mean to say you're community-based or you have community engagement. So those were some of the first initial things, I think, that where we had input from our program activities, and because we were able to help merge those things together, we did see some better outcome, especially among our program participants. But one of the things also would include we were able to raise the awareness of the problem of infantility in Jefferson County, but more specifically in the Birmingham Healthy Start areas, which was most of Birmingham, all of Bessemer, and all of Fairfield. And like I said, we saw that there were better outcomes among program participants, those who participated in the program. as compared to those who were eligible because they lived in the area but did not participate in the program. Dr. Richard Sinsky, who was part of the health department at that time, and he played a major role in getting a lot of evaluation stuff for us. That's one of the things that he would do every year, was show us a comparison between those, and we could see that we were on track. We would see that there were better outcomes and even good outcomes, actually, as relates to our objectives among the participant of program Birmingham Health to Start, whereas in the overall area, the rate would still be a little bit higher. So we knew that we were doing, having an impact. Also, we saw enhanced knowledge as it, through our childbirth and education, parenting skills, and those other areas that impact perinatal outcomes. Our home visitation services and screening through our trauma-informed care approach led to better compliance with treatment regimens among our program participants. And that also included a decrease in missed appointments. For those, and we saw that for those who were program participants, because of the way we kept, the staff, tracked them and provided their ongoing supportive services for them. But those are just some of the things. But one of them, the significant things that I saw also was that we were very instrumental in showing the significance and being involved in the ongoing evolution of father engagement in the MCH arena, because at early days, you didn't see it. I started off with the health department before Health to Start, working in the maternity, pediatric, and family planning clinics. And I would notice that the fathers would come, they would drop the young ladies off, and they would go on, and when they did come, they would sit in the waiting room. They were not allowed back in their areas. And when we were doing some investigation and even talking with the providers, some people just felt that fathers just did not want to be involved. And again, you can better get this from a father. And we have one on the panel who can attest to the fact that, yes, they very much want to be involved, the whole 9 yards. So we quickly got that dispelled, and now we are seeing a more involvement of that. We're seeing the evolution of that fatherhood inclusion in the MCH arena, more so now today than we did years ago. But like I said, the father could speak more to how important it was for him to be involved in it, and which is in direct contradiction to what the initial thoughts were that fathers just didn't want to be. So I get back to you. I can't give me.
I apologize. My habit. So definitely, yes, I do want to touch bases with Mr. Johnson, and we'll circle back to you, Dr. Bradley. But Mr. Johnson, how has your role as a father contributed, you believe, to the healthy birth outcome with your daughter? You and I have had some conversations before. Certainly you kind of talked about the prenatal care piece, nutrition, and so forth. Talk to us a little bit. Tell us about what you think happened during that process and you supporting as a dad helped bring that healthy child into the world.
I can say it helped make the process more smoother, as far as, because my wife didn't have to do it all on her own. I was very concerned as far as not only as her health, but as my baby's girl health. Made sure as far as eating right, exercising. We used to go walking. Make sure she took her prenatal vitamins. I was there for the majority of the appointments. I was able to take off work and for the allotted time and attend those appointments with her. So any information that she got, I was getting it firsthand also. And so it was very helpful, because as Mr. Green mentioned, it's the stipulation that fathers don't want to be there as far as throughout the whole process. And it's just, we step in when the baby is born, but we are actually involved in throughout the whole pregnancy, because not only being involved teaches us, it also relieves the stress of the mother. So she don't have to she's not stressing or about all this information, what's going on and stuff. So with me personally, I've attended majority of the appointments. I'm not gonna say I attended all like I wanted to. I attended majority of the appointments. I made sure, you know, we ate right, and I say we because I know if she did it, I had to do it also because we're a team. I just couldn't have her eating right and I'm pigging out. You know, it wouldn't be fair. So I made sure we ate right together. As far as when she also, my wife was also part of the Gift of Life first time mother program with the at home nurse. When her nurse used to come by, I used to try to be there so I could gather information also because, you know, at this point we're speaking on the health of our babies. So I want to know as much information as I could take in.
Okay, very good. So it sounds like really education was really key for you. And also with all of that, it was an opportunity, you being present, help reduce the stress for your wife. One of the things I think sometimes maybe people in the community forget about is infant mortality. We're not just talking about on the front end, the stillbirth of them being born, but we're talking about up to a year of age here. So one of the things that you talked about with me, and I just want you to address it a little bit today, you talked about postpartum depression because, you know, having a small child, and I remember those days, it requires a lot of attention.
Yes.
They require a lot of our attention. Can you talk to us a little bit about how you supported her, or just talk about that process of experiencing or seeing that postpartum depression?
Okay. So, you know, after my baby was born, I went back to work. So, you know, I had to take care of the family, but I also saw how draining it was also for my wife because, you know, with a newborn baby, you're constantly up throughout the night, you know, and throughout the day, you're barely getting rest. So I kind of noticed that she was slipping. So what I would do personally as to assist when I got home from work, I grab my baby, and she's all mine. Go get your rest. I used to have to crazy thing about it. I used to have to force her to get out the house. Like go do something. Go get out the house. You know, even though you're not going back to work, don't sit in the house. Go. The baby is good. You know, and I feel like it's very important because as a woman, you know, I can't speak for a woman, but as seeing my wife, she slipped into that depression mode. It was a hard place for us to get her out of because, you know, it was not only her, but as her husband, I was like, you know, what can I do? How can I help bring her out? You know what I'm saying? And what made it even harder for her is that my wife lost her mother when she was 17 years old. So her mother wasn't around when she gave birth. So I had to fight extremely hard as far as letting her know, hey, you're doing an awesome job. You're a wonderful mother. I know it's tiresome, but you're not doing it alone. Hey, I'm here with you. There's be times she'll try to get up when my baby used to cry in the middle of the night. I got this. Go back to sleep. You know, I step up because, you know, how can I say this? Society or social media put the stipulation that the father just go to work and just provide. But not only being a provider, it was key that I actually stepped in and did things as far as changing a diaper or swaddling, or I even find myself singing lullabies and stuff, you know, and that helped relieve the stress as far as to help relieve the stress as far as getting out of that whole depression state. And as far as it kind of gave my wife a sense of calmness, like, hey, he's here. You know, he's actually helping, he's available. And so that's why for us being a father, is very key that, you know, we help fight this fight with our mothers that do go through postpartum depression. We get them to seek help because it's always good to talk to someone. And even though she wouldn't talk to me, I've contacted her nurse. I was like, hey, she's slipping in. I need some information. And she was right there and got her the help that she needed. And it just very key to keep an eye open for these things because after they get out, or it's very appreciative when they do get out of that funk, I would say, or that stage in life where the postpartum. And it's also helped with abundant time too with my daughter, as far as she's a daddy girl. So it's like, it's wherever I go, she want to go. So it helped not only having abundant time with her also. So it was good as far as it definitely pushes me to actually be more attentive to what's going on in my surrounding instead of just, hey, going to work and, oh, you the mother, you do this. No, that's taking charge and being involved and help raising that baby.
Absolutely.
We applaud you.
Yes, absolutely. And I think that's where, programs like this is just a prime example of how important they are in the great education that can come out of there. And also him touching about a really real topic that a lot of people don't want to talk about and don't want to address, but it's real, and he got to see that. So thank you so much for your candor. Dr. Bradley, I did want to pose the same thing to you and asking how do you believe the Stork's Nest has impacted the community in relation to birth outcomes, and certainly talk about some of your research as well as a professor.
Okay, so I would start, and this echoes a lot of what's already been said, but just in our incentive program, one of the incentives that we have is to have the moms bring a support person with them to our education sessions. And so that's an incentive to bring the partner, to bring the grandma, to bring the sister, the best friend, to also be there to hear the material as it's being presented. So that's hopefully reinforcing some of the information that's learned and maybe even increasing some of the dialogue that's happening outside of those spaces, to where they can go back and really talk about, like, what does this mean? What does this mean for me to eat healthy, or what does it mean for me to get more sleep, to take care of my mental health, to get more physical activity, and that kind of thing. We also, this is a lot about education and about making sure that they understand what it means to eat a better nutrition, have better nutrition overall, or have better sleep habits. We also have content experts in the community that come in to have these discussions with moms, which I think is really powerful. So we have, nurses and dietitians and other, community experts come in and talk about sexual health. They talk about contraception use, after you deliver. So what's your plan? Like, we, get down and get some really good feedback from moms about, how are you going to, what kind of contraception are you interested in? What questions do you have about that? We talk about stress. We talk about how to relieve stress. We talk about substance use, and, we talk about postpartum depression and what are some of the symptoms. Like the dad mentioned, like, what are some things I need to be looking out for? And when I see these things, what do I need to do? Who do I need to call? We also, part of the incentive program, as I mentioned before, is incentivizing them to go to the WIC office to, take advantage of those services. So we give them points for any WIC appointments they have. We give them points for all the prenatal visits, and even after they give birth, giving them points for keeping that postpartum visit, because we know that that's an issue for a lot of women, is that they don't go back and they don't go to the postpartum visit. And so that's a way that I think we're able to impact some of those outcomes. And then safe sleep, making sure they understand, the principles behind safe sleep, making sure that we're giving referrals. And if they don't have a bed, or they don't have a safe place to put the baby, and making sure that they, prepare themselves for that kind of thing is really important. And I think that's how we may impact some of those outcomes.
Okay.
As far as term, I would say it's the same thing as far as education. When we did some focus groups with moms ahead of time to kind of set up what was the content that's needed to help with those, change some outcomes. One of the moms' biggest responses to that is, please help me understand what's going on with my body, because sometimes doctors talk to me and I have no idea what they're talking about, or they're not using language that's familiar to me, and some of them said, hey, use the terminology so I can go back and look up that specific word. Like, I want to know the terminology so that I'm more knowledgeable about what's going on with my body. And so with the TURN program, we had nurses also do home visits. And so they were able to have that one-on-one time with moms and sometimes also the support team to talk about, what's going on with my body, how can I eat better? What are some things that I can do to relieve my stress? And just sometimes just talking about things it's really interesting, the amount of emotional support that's needed and that women don't have. And I think that may even contribute to some of the postpartum things that are happening afterwards. So just having that person, that non-judgmental person to come and be able to unload and talk about what's going on in their life to relieve some of those stressful things, I think is really important.
Right. Awesome. Thank you so much. So what I'd like right now is for each of you, starting with you, Ms. McDaniel, to tell us about some of your partnerships. And I think you talked a little bit about them in the community, but also how has some of your work maybe changed since COVID-19? Because I think we need to address that.
Yeah, definitely. Like I said, we have great partnerships nationally and locally here in Alabama. Sometimes our national partnerships trickle down and we have more local connections as well, like with Zeta. And we know at March of Dimes that changing infant mortality and the trends that are happening in the state as well as our country it's a group project. It's not one entity that lowers the numbers, but it's a collective push for better care, better infrastructure, and better policy. So we really rely on our partners to guide us. We want to know, what are others doing? What are the gaps? What do they wish they could do, but they don't have the manpower that we can step in and do that part for the community? I go to the Department of Health, to Zeta Phi Beta, to Gift of Life, to Alabama Care Network, all of these people, the universities, ALPQC, I go to them and I say, hey, I have an idea. Is it good? What am I not thinking about? Is there someone else doing this? And I have ideas and thoughts, and March of Dimes has ideas and thoughts, but if it doesn't work for Alabama, we're not going to do it. If someone else is doing it in Alabama, we're going to promote that work, not try to create something that's going to take away from whatever that work's doing. Everyone is a potential friend. That's something that I've learned through my predecessor, who, everyone is someone who can help push this issue forward so that we can make a difference. And we're going to our legislative body with our partners, with Alabama Association of Pediatric and the Medical Association, and saying, what are you working on in Montgomery? What's your agenda? Can we go together and talk with them? Like in partnership with the Medical Association in the state of Alabama, we were able to get the Mortality Review Committee funded from our general budget. That wouldn't have happened without a partnership. And we do different things than our partners. So while Zeta Phi Beta and Source Nest are given that information and they're raising awareness around prematurity on a very local level, we're also going and pushing forward the things that they hear from their moms. They come back, they tell us, and we say, okay, great, we'll go and we'll try to make that better in the community. We heard the moms don't have a doctor nearby that they trust. All right, let us go talk to our other partners about what we can do about that. Hey, our moms are really upset that they lose their Medicaid after 6 weeks. Okay, let us go lobby that. And with COVID, we kind of saw that change come in two ways for us. So we saw the need for resources when it happened. And my predecessor, Britta, she did an amazing job helping March of Dimes nationally spearhead educational resources, support documents. We have Facebook Live events. We added a COVID section to News Moms Need to Know blog. Okay. We shifted some of our research to this COVID, just like everyone else. However, we saw that our partners were really digging in. So we're saying, okay, they're on the front lines. We're partners with hospitals. We're partner with people who are working with these families. What can we do to support them? Is that holding down the fort on some project that they no longer could really give their full attention to? Is that sending food to the hospital? Is that really taking over, even setting up a meeting with someone. They're doing all of these extra hours. So we respect that. We want to support them, and we want to help with that bandwidth. And it's a scary time to bring a baby into the world. More than ever, women need support and they need someone to have their back. Fathers, they want to feel like they have control and be able to tell their families, hey, this is what we need to do, or like need to know, how do I support my wife while she's pregnant during a pandemic? We can get that information out there, but we also can take away some of the other stressors so that it's not just 5 different stressors. Now we've taken away something, and and they can focus on not getting COVID. They can focus on not going out. They can hear that it is safe to get the vaccine while you're pregnant. And so we didn't want to stop our efforts. We really did want to hold down the fort so that our partners could focus on what they needed to focus on, but we could still make a difference, because there are still babies being brought into this world. At one point, there were even more babies being brought into the world when the pandemic started. So there's other ways to have a healthy pregnancy, and there's ways that we can take these lemons that we were given and we can make lemonade. People are grasping for information about COVID, about how do I have a baby during a pandemic. Well, you can have a baby during a pandemic this way, specifically because of COVID, but also you can have a healthy pregnancy this way. We're getting them information that they may not have looked for before, now that they're looking for COVID. So again, lemonade out of lemons during COVID as much as we can.
Awesome. Thank you so much. Mr. Green, the same question about your partnerships in the community and how your work may have changed with COVID-19. You're muted there, I believe.
Sorry about that.
No problem.
As I mentioned earlier, we've been around for 30 years, so we have an array of partners within the community having done that. One of the things is that in doing so, we showed how demonstrated how we can see have better perinatal outcomes with such problems as infant mortality and maternal mortality and morbidity, and other poor perinatal outcomes when approaches are taken in collaboration and partnership with others. And that's what we're seeing over the years, because areas where Birmingham Head Start plus lack, then we have real partners that pick up on that and vice versa. We have worked, and I sometimes don't like calling out names because you may miss somebody. There's so many. So if they happen to miss your name, it's not because you're not important to us, because you really are. But most of the MCH providers in the areas we've been working with for years, like Alabama Regional Medical Services, where we were once funding our umbrella, the Jefferson County Department of Health, of course, UAB Maternity, Princeton, and other private providers, and working with the medical providers and even the like care coordinators or other staff to develop this comprehensive team approach. But then there were others like the Dana Project and JCCEO and United Way, March of Dam. We have been actually funded for a couple of projects from through March of Dams. And just participating in the regional MCH committees and infant mortality review committee and maternity mortality review committee, to where we were able to contribute and able to learn a lot, a lot from that. So those are just the name a few, and then an array, of course, of just community-based organizations that we've just worked with over the while. It makes a whole lot of difference. Like as I had mentioned, when you're working in partnership with others and you're trying to tackle outcome issues like those that we are talking about today.
Right. And how has your work changed since COVID-19?
Oh, I'm sorry. Well, since COVID-19, Uh, the main thing that changed was that one-on-one, face-to-face, and that personal touch that we like to provide for our clients. Although we've tried to find ways to get around it, like drive through, and when it was safe enough through some safe distancing type approaches. But one of the other things that we saw that was significant is to see how the COVID-19 impacted our clients, and how can we as agencies, not just Birmingham Health Start, but others, support them during that time. So we did a survey, and we had some discussion about this during one of our last CAN meeting. And one of the things that came out of that survey from our consumers was that what COVID-19 did for them is like it kind of sort of took away some of those pleasurable moments of being pregnant, like making the announcement with family members around you, or even having, that birthing experience when, yes, you have someone in the actual delivery room with you, but you have others out in the waiting room waiting, to get the good news and applaud you. They miss all of that. But one of the things a person, a few of the individuals spoke about was that in most of the time when they went to for their prenatal care, because of the safety issues, even when the father would bring them, they may have to stay out in the vehicle. And I think some of them may have to stay out in the vehicle until they came in. But when they went in, they went in alone. And what was pointed out is that a lot of people, from this particular young lady, was a lot of people, a lot of providers don't realize that although, pregnancy is a enjoyable moment, and often more than likely outcomes are good, but every time they go to the doctor, there's some kind of anxiety because they don't know what the doctor may say. They don't know if they may listen and don't hear a heartbeat or whatever, and they don't want to experience that alone. So, and that was a big problem. And we will be talking to some of our providers to see how can we get around that. Should we have to deal with something like that again? And some suggestion was like, even if they had some kind of walkie-talkie or something, well, they're in that room and the father's out there and can help talk them through. I can hear, because they don't want to get bad news and have to deliver it to somebody. So I thought that was very important. And to me, that was one of the most impactful effects of COVID-19 for our prenatal clients.
Thank you. I'll just quickly chime in because I think most things have been said in relation to our program, but we certainly have partnerships like with our local Alabama Department of Public Health, Birmingham Healthy Start Plus, and one of the initiatives, things that we do is host this Infant Mortality Summit. We think it's important for the community to know what's going on and to try to bring the best experts in the community to talk about it, what basically to keep you up to date. Some of the other things we do, we collaborate with the local pregnancy centers in the area. We collaborate with the WIC office, local hospitals, doctors' offices. Mental health facilities have really even become a bigger partner, I think. Since the inception of the pandemic, we've just seen a significant rise in that. And I would say not just from clients, but employees as well, because we're all challenged with doing something totally new that we had not done before. So in terms of COVID, we were, I guess there's a blessing maybe out of some of this, you can say, but we had to have the mobile family coaching, which I mentioned earlier. And so we were already doing something similar to this, if you think about telehealth. So it made the transition a little bit easier for us to do it, but that's what we are doing now. And just as Mr. Green indicated, we are doing drive-bys, if you will, dropping off resources to clients and information, and occasionally try to do lawn visits, certainly implementing good practices while we're there. So we'll continue to do those things, hopefully until this resolves and goes away. But I want to ask Dr. Bradley the same question, about partnerships, and you talked about some of those and how COVID-19 may have changed your work. And then I also want to address Mr. Johnson in terms of his care of his child with COVID-19. So Dr. Bradley, we'll start with you first.
Okay, so I'll try to be as brief as possible. So the Stork's Nest has pivoted to a virtual e-learning platform to where moms can register for self-paced modules.
Okay.
And these are in English and Spanish, which is great. And they have 3 months to complete 10 sessions. And in each of the sessions, they get a $10 gift certificate for each session that they complete. So still with that same incentive-based program. And then they get a $25 final gift card once they complete all of the sessions. There is a virtual graduation ceremony. And we still pair that with some synchronous learning opportunities with different content as local content experts to kind of get a more in-depth conversation about some of the different things that they're learning in the modules themselves. And so some of our Stork's Nest programs have opted in to partner and make that available. There are some might still be in transition. So I'll give you a link at the end. Well, I'll give you a link a little bit later so that you can know where to go to see if those local Stork's Nests have that option. We also developed something called a birth equity track because, again, we understand based on the conversations that we've had so far is that there's this greater emphasis on some of the other I think COVID has shed a light on some of the disparities that exist for certain populations. And so one of the tracks is basically for food access or food insecurity. And so we have a partnership with the local food pantry to where we have mobile food pantries. And again, like Mr. Green mentioned, having like drive-bys where families can literally go and pick up their groceries in limited exposure kind of situations and get, access to food in that way. There's also another option to do with access to transportation. Because again, as we've mentioned, as I think several people have mentioned, there are a lot of barriers to get into your doctor's appointments. And so partnering with local OB providers to identify some of their patients that might be having those difficulties. And then the Stork's Nest or Zeta chapters will provide vouchers or transportation vouchers or some kind of way for them to make it to those appointments. So if you're wondering if your local Stork's Nest or local graduate chapter is participating or using any of these programs, you can go to www.awesomealabamazetas.org. I will say that some have a designated Stork's Nest on that website, but some don't. Ours isn't on there, and I know that we have one. So don't use that as just to be mindful that may or may not be accurate. So, but it does show the graduate chapter and the city or county that they service, and so you can use that as a resource to see what programs are available in your area.
Okay. Awesome.
And I would say from the work that we did from a research perspective, we did notice that there was there was a great need for mental health services. And so what we did was we set up an option for our participants to opt into telehealth appointments with our psychologist, who was an employee of the University Medical Center. And so they were able to have telehealth services provided to them free of no charge, just to kind of deal with some of the issues that we talked about. So the issues around the uncertainties around COVID, being able to go to your appointment, just and not being able to have access to that support person in the room with you. A lot of people had a lot of anxiety around those issues. And so we were able to get that resource for them to kind of deal with that.
Okay. So thank you. So we'll wrap up in a second and we'll talk about contact information, but I want to go to Mr. Johnson real quick and just kind of ask, when a child is first born, you just have those basic worries that you talked about earlier on, the monitoring, making sure they're sleeping in a safe environment and all of that. But what has changed for you now? Your child is a little older, but you have COVID-19 that's in effect. What has changed for you as a parent, as a dad?
As a parent, her appointments, that's one of the biggest changes. Both parents wasn't able to go on the inside. So, that's something me and my wife had to rotate, take her to appointments, because that's something we both like to do and try to be involved in. That changed tremendously where, I was able to go to every appointment that she has for his checkup. Now I have to, hey, well, you go this time or I'll take her next time, just to stay involved. Also, it's just trying to protect and stay safe as far as because I actually ended up getting COVID early this year. So I had to go to Birmingham and quarantine with my brother just so my wife and my daughter couldn't get it. So it's also protecting myself and make sure I'm in good health also to not expose her to any type of dangerous situation. So it heightened my sense of safety since this pandemic, and I'm trying to take in every precaution just to stay safe because I'm not only looking out for myself now, I have my daughter I have to look out for. Even though she's 2 years old, I have to make sure, hey, don't grab this or hey, pay extra attention, extra cautious on where I'm going. Like it was mentioned before, if I don't have to go inside a grocery store, I don't go. I order my groceries online and do grocery pickup. I try to not go a lot of places where I know, because it's in the air, but I try not to avoid packed places where me or my daughter may be because she can't protect herself. I have to do that. So as a parent, it just really put an extra protective, cautious mode in me where I have to basically see and make sure she's okay.
Absolutely. Awesome. Thank you, Mr. Johnson. So can you all briefly, I want to make sure everyone knows basically where you are. So what areas do your programs serve? And I'll just briefly say for the Gift of Life Foundation, we are in Montgomery, Otaga, Macon, Russell, Pike, and Crenshaw counties right now. What about you, Mr. Green?
So our physical location is in Birmingham, but the service areas are Birmingham, and it's only maybe like a couple of neighborhoods in Birmingham, that we do not serve in those areas where there was not an infant mortality issue. Okay. But most of Birmingham, is included in all of Bessemer and all of Fairfield. So those are the target areas that we serve.
Okay, thank you. And Dr. Bradley, is the stork nest and other locations that individuals can find?
Yes, I want to say there are at least 5 chapters that have active stork nests, but there may be more. Okay. And so again, I just invite everyone to go to the state website and have a direct inquiry with the chapter that's in your area to see what's available. As far as my research, as I look into moving into developing that doula program, I want to start the process in Greene and Hale County. Not to say that it won't be expanded, but those are the 2 counties that were basically recommended to me to start doing the work, and then hopefully we'll expand from there.
Awesome. I think that's an area definitely to look at, and we will have further conversations today from some doulas that will be on board. And then Ms. McDaniel, the same question about where can we find you?
Yeah, so I'm located in Birmingham. However, I serve the entire state. I have partners throughout the state. We make sure that we're connected in all of the counties that we can be. If any of our programs can be used in any county as long as we have that partner there. So we're lucky in the fact that like we get the whole state. Everyone's ours.
And then Ms. McDaniel, I'm going to start with you and then circle back. If people want more information about your programs, how can they reach you? And is there some information you can put in the chat box for them today?
Yeah, absolutely. So if you're interested in March of Dimes in general, marchofdimes.org, I'll put that in the chat. I'll put our blog in the chat, News Moms Need. But if you need me, I can also put my email in the chat since I am the Alabama contact. But yeah, those are the three things I'll put there. Yeah, and we do a lot of professional training, a lot of implicit bias training, and that supportive pregnancy care. So that is all on our website if people want to.
Thank you. Mr. Green, the same question. How can we reach you and what information can you give us in the chat box?
So actually, we can be reached by the office phone number. However, we're not there like I think we're only there like maybe 2 days out of the week.
Okay.
I could put that phone number in the box. You can call my number, and I'll put that number in and my email address in the box. And we are in the redevelopment stage for our website.
Okay.
And once that's done, that would really be the best way to get us.
Awesome. Thank you so much. And I think Dr. Bradley, did I capture you regarding that information? All right. Just want to make sure. So the last thing, I know we're getting ready to close out, but I wanted to ask Mr. Johnson, is there anything that he would say to providers out there or other consumers, fathers like you, why they should connect with programs such as Fathers in Action with the Gift of Life or other programs like at the Healthy Start Plus program?
I think it is very important to connect with these programs due to the information that is given. It is top tier. I mean, I know we have the internet, but when you have that face-to-face with someone, especially a father who, experienced the stuff you're going through, is the information that you're given and the support is second to none. I can say my coach, Mr. Jesse Yates, he was very supportive throughout the whole process of my daughter, throughout the pregnancy and being born. So to have that physical support, someone who I could call, it was very needed. For me, I would say it was very needed. I felt like it helped me become a better father. And even to this day, even though I just recently graduated the program, I still could contact Mr. Jesse if I have any questions. And so I think as a father, it's great what they're doing, and it's also very beneficial because, as we know, there are a lot of programs for mothers out there, but for a dad to actually be involved or want to be involved, I would say get into it as soon as possible because it not only helps you but you're learning so much that I can't even explain everything you're learning. It's a great opportunity to actually learn more about being a father from a father. So that's why I would say why someone should actually take advantage of the program.
Thank you so much. So just a quick note, and I'll place it in the chat also. You can find the Gift of Life Foundation at www.golfound, short for foundation.org. I want to thank each of our panelists for joining us today and providing a wealth of information and insight. And thank you to those in the audience for joining us today. Have a good day.
Thank you, panelists. We have audience, there are the information, the contact information for the panelists and their websites are in the chat box. And I just want to double check because I thought there was a question.
I can respond to one question. I'm not sure if someone answered it earlier. It was about whether or not, the criteria basically for someone being enrolled in the programs. Are they Medicaid only, et cetera? And at the Gift of Life, they are Medicaid eligible. Women, Medicaid eligible, WIC eligible clients that participate in our particular program. I can't speak to the Healthy Start Plus program.
Yes, the question is, are the women enrolled Medicaid only, or can you be enrolled regardless of your insurance income category?
Can you hear me?
Yes, sir.
So for Birmingham Healthy Start Plus, it's not income based or anything. If you live in the Birmingham Healthy Start area and you are pregnant, and you have a child that's like, yeah, well, actually we say up to 2 years old, but let's say newborn, up to maybe 8 months, and you live in the area, but regardless of income, race, whatever, you are eligible to be enrolled into the program. And that will also be if you are a father and you have you're a new dad, or you are expecting dad, and you live in the area, in the mother, you don't necessarily have to live in that area, but the mother to be and our child will have to live in the Health Start area, and you're eligible to be enrolled into the program as a participant. But if you want to get fatherhood support, even if you didn't live in the area, we can enroll you. We just won't be able to count you as a participant.
Wonderful. And we do have other programs, community programs similar to these in Mobile, in Jefferson. I think there's home visiting in just about every county in the state. I believe I heard that through the infant mortality reduction plan. I know that's really helped to spread home visiting, but we will verify that. And the last question I see is asking, are agencies encouraging their pregnant clients to get the COVID vaccine? I know at ADPH, we are following the CDC guidelines and recommendations about vaccinations. Would anyone else like to respond to that?
Yeah, I can talk a little bit about that. So a lot of different partners came together and did give out a statement that says we are encouraging the vaccine in pregnant women. I know that there have been a lot of women who heard one thing from the doctor, and then all of a sudden the doctors are saying, yes, get the vaccine. While a long time during their pregnancy, they weren't as encouraged to get that vaccine. But it's been the same throughout the time of the vaccine. We know that we see horrible outcomes for moms who have COVID during pregnancy, whether that's loss of pregnancy or even death after. Hopefully they are able to save the baby with an emergency C-section, and then we've lost moms in the state to COVID. But we have not seen any long-term side effects from the vaccine, and luckily, we don't normally see long-term side effects from vaccines in general. That's not normally something we see. But definitely encourage pregnant women to get vaccinated. It could really not only save their lives, save their babies' lives, and those babies deserve to have their mom or their dad there as they grow older. We've seen some really bleak outcomes for women who have COVID, and you're having trouble breathing because you have a baby, and now you're having trouble breathing because of COVID, and you're having that push in your lungs from that baby. And so definitely encourage pregnant women to get the vaccine.
Thank you. Okay. Thank you, panelists. I just want to reiterate Dr. Traylor's thanks. The audience is saying thank you to each of the panelists. That was great and needed information. Wonderful answers to those questions. Thank you to Mr. Johnson. Everyone appreciated you sharing your story and having the point of view of a parent, a father that is actually using the services offered by our community program. And before we go to lunch, we're going to do a quick polling break. That's coming up. There are like 4 or 5 questions. If everyone could respond to that really quickly before they move on to the lunch break, we'd appreciate that. Thank you. The other thing is, Mona, I think, has already or will be sending an evaluation to those who need CEUs, nurses and social workers, so be on the lookout for that. Okay. So our next session is Maternal, Fetal, and Infant Mortality Review in Alabama. Our speakers are Dr. Glenda Smith, who is an assistant professor of nursing in family, community, and health systems at the University of Alabama. And then we also have Lindsay, who is I'm sorry, we had a change and I'm missing her last name. Lindsay, are you here yet? Thank you. Lindsay Harris, our program coordinator for the Maternal Mortality Review Program. She's a program coordinator for the Maternal Mortality Review Program and Committee. Thank you, Lindsay. Thank you, Dr. Harris. Okay. Do you all have anything to share? Okay, thank you.
Well, I guess I'll get started. Good afternoon, everyone, and thank you for giving me the time to address some of the 2019-2020 Region 5 Fetal and Infant Mortality Review and Community Action Team activities. First, I would like to thank the members of the review team, especially Mrs. Shirley Daniel, our Region 5 perinatal coordinator. And I would also like to thank our community partners that help us to provide the activities that help us to promote the health of women, infants, children, and families here in Region 5. What I'm hoping to do today is to give you some of the Region 5 case review team recommendations. As you know, we review cases and then we make recommendations to the case review team so that we can make changes in how we address infant health care. As you know, and you've heard some of the statistics today, many of our cases have to do with safe sleep and sudden unexpected infant death. And so some of the recommendation that we have for that is to continue to provide safe sleep education to parents, to reduce the number of infant deaths related to unsafe sleep environments. And we have done a number of action items to help in this process. The River Region Community Action Team has disseminated the National Institute of Child Health and Human Development Resources and Education to expectant moms, new mothers, family members, area birth hospitals, OB, pediatric, churches, as well as health departments in the region. We also promote the Alabama Cribs for Kids program to ensure that all of the infants under the age of 1 have a safe sleep environment to reduce the risk of sudden unexpected infant death. Region 5 also is partnered with the 9 delivering hospitals in the area to participate in the Alabama Safe Sleep Baby Book Initiative through Charlie's Kids Foundation. And those board books are distributed to every new family to provide education about reducing the risk of sudden infant death syndrome or sudden unexplained infant death. These books are available in English and Spanish, and they're used as a teaching tool to start a conversation about safe sleep. Another recommendation that we have, along with infant loss, we look at infant loss, grief support, and referral for families. And that is a very important concept, especially after suffering infant loss. And so the recommendation is to provide and increase adequate grief referrals and support for women and their families following a fetal or infant loss. And so what the River Region has done is disseminate grief resources, resource booklets, reading materials, music, songs, videos, and support for final arrangements to grief support counselors, Facebook sites, websites, and peer-to-peer support groups, as well as to families and healthcare providers, case managers, and funeral home directors. Law enforcement as well is involved in our review team, and so the team continues to be active in supporting the law enforcement in providing information on those cases, and I'll talk a little bit more about that. We also have another action with the Gift of Life to hold a candlelight memorial event across the river region, and for anyone who's experienced a pregnancy or infant loss. And that event was held virtually this year via Facebook Live, and coincided with the international Pregnancy and Infant Loss Remembrance Day. When it comes to training our partners in the field, that's also important for the community action team. And so what we do, the recommendation is to provide refresher training on the dynamics of domestic violence to OB providers and clinics, provide safety plans to OB providers and clinics for abusers of domestic violence. We also provide refresher training to our first responders and law enforcement to improve on the scene documentation as well. And so we have partnered with the Gift of Life and the Alabama Coalition Against Domestic Violence and collaborated with a workshop, the cultural awareness of dynamics of domestic violence, and that was held in October. A retired Lieutenant Steve Searcy, a law enforcement training coordinator, has participated and gave 2 presentations. We also had Bethany Warren participate from the victim advocate from One Place Family Justice Center, also created presentations. And then Sharon Monteith talked about her experiences as a victim of domestic violence and how her journey inspired her to create her company, Women of Refined Gold Incorporated. We've also had lunch and learns to provide education and training to our law enforcement in Region 5 to improve their documentation that is required by the CDC sudden unexplained infant death forms. Our most recent training collaborated with the Alabama Child Death Review to provide that training for local law enforcement in August. As we all know, education is one of the keys to the reduction of maternal, fetal, and infant mortality. And so the final recommendation is to educate moms on the importance of being healthy, the importance of prenatal care, nutritional counseling, and care of newborn babies. And the community action team participates with the Zeta Phi Beta sorority and Alpha Rho Zeta chapter, Stork's Nest, which aims to increase the number of women receiving early and regular prenatal care to prevent cases of low birth weight, preterm births, and infant deaths. Participants are referred either by a physician or by other healthcare workers, and they earn incentives as they attend the curriculum sessions, doctor's visits, and other events which promote healthy prenatal care. Those incentives can be used to also purchase larger items such as diapers and baby clothes to cribs, strollers, and car seats. The program has recently offered diabetes classes via e-learning to address food insecurity and to provide moms with a $25 gift card once they complete that program. The Gift of Life Boosting Breastfeeding Workshop was held in March at Trentham State Community College, and that is to make breastfeeding more friendly in Montgomery. We promoted and attended the first showing of the Wellness Coalition's documentary entitled Chocolate Milk, which provides education and support to increasing breastfeeding rates in African American women. The Wellness Coalition Breastfeeding Campaign also advocates for the normalization of breastfeeding. And the Community Action Team exhibited at the Summer Health Fair and promoted better health through prevention and intervention at one of our local churches, Mercy Baptist Church, and provided educational materials, talks related to perinatal care to the parents that attended. We also collaborate with the March of Dimes to provide educational resources, as well as the Early Head Start Health Care Partnership, where we provide parents with pertinent perinatal information. That concludes my portion of the discussion.
Thank you, Dr. Smith. Lindsay?
Okay, good afternoon. I'm honored to provide you all with an update of the Maternal Mortality Review Program and Committee. The Alabama MMRC is a multidisciplinary voluntary team, which is comprised of professionals from various organizations, disciplines, and backgrounds from across the state. It provides a diverse lens to assess the circumstances leading up to a maternal death. The goal of the committee is to better understand the factors that impact maternal deaths and put forth actionable recommendations in hopes of mitigating and preventing future deaths. The MMRC aids in this goal by reviewing deaths of women that occurred while they were pregnant, as well as within 1 year of pregnancy. The MMRC sits within the Alabama Department of Public Health Bureau of Family Health Services. The Bureau formed the program using the framework of the CDC's ERASE-MM, which is Enhancing Reviews and Surveillance to Eliminate Maternal Mortality. ERASE-MM informs the process in establishing a committee and its goals. Before the COVID-19 pandemic, the MMRC met face-to-face quarterly to review the maternal deaths that had occurred within our state. We are currently reviewing cases from 2018. During this review year, the MMRC added homicides as well as motor vehicle accidents and has reviewed 30 cases so far. We are very proud to say that the Alabama MMRC has stayed intact and functional despite the barriers set in place by the COVID-19 pandemic. Maternal mortality is a national crisis with sobering statistics. It is associated with complex and multi-layered factors such as barriers to healthcare access, racial and ethnic disparities, and social determinants of health. The Alabama MMRC not only reviews the medical circumstances surrounding the death, but also looks at a multifaceted approach to review the entire life course perspective of the woman. We know that reviewing the entire life course perspective is crucial in making impactful change in pregnancy and birth outcomes within our state. I would like to take a minute to share the accomplishments of the MMRC and the MMRP this year. We are proud to say that our first report from our first year of reviews was published in October of 2020. It highlighted the data and recommendations that were made by the MMRC. Next, we have provided an implicit bias training to all of our MMRC members. Now that we've had our implicit bias training, we plan to begin using the most recent version of the CDC's data collection form that includes racism and discrimination as contributing factors. We know that using this form will bring up crucial conversations and recommendations within the MMRC. Another accomplishment includes the forming of a policy subcommittee that meets quarterly to discuss and review recommendations that have been made by the MMRC pertaining to policy change within our state. The Substance Use Disorder Subcommittee was also formed this year to help identify and share resources that are available to providers and the public. Because of this significant increased impact that COVID-19 has had on maternal health, the Maternal Mortality Review Program decided to review cases related to COVID-19 in real time. We hope that in doing so, the MMRC can make recommendations that will improve outcomes for mothers diagnosed with COVID. One of our most exciting accomplishments has been that we have received funds to perform maternal autopsies on every death that occurs within 1 year of pregnancy. Of the deaths reviewed for the 2016 year, only 18 out of 36 had an autopsy performed. The funds that have been received will help in increasing access to autopsy services by eliminating significant financial barriers. These autopsies will be provided at no cost to the families or to the counties of Alabama. The program will be in place this fall. We would greatly appreciate your help in spreading the word about this program. The information gained from maternal autopsies is crucial to understanding the cause of death and bringing improvements to maternal health. The MMRP and MMRC, of course, have goals to accomplish in order to continue our purpose for improving maternal health outcomes. One of the goals that we have begun working on is establishing a process for next of kin interviews. With the help of a Master's of Public Health intern from UAB, we have established a process from start to finish that will accomplish this goal. We know that including these interviews in our process will greatly enhance the information related to a woman's life course perspective. Another goal of the Maternal Mortality Review Program is to publish the report that communicates the data and recommendations to include both 2016 and 2017 maternal deaths. We expect this report to be complete this fall. Thank you so much for your time today and for your contribution to improving infant and maternal health within our state.
Thank you, Ms. Harris. Thank you for jumping in there. I know we had that last minute change, but we appreciate all the leadership you have given to the Maternal Mortality Review Committee and the Maternal Mortality Review Program. You all have made great strides over the last couple of years, and we thank you for sharing that information with us today. I do have a couple questions for you and for Dr. Smith. I know that I introduced you, Dr. Smith, as a professor at UAB. Not sure if she is still here. I can't see. There you go. Okay. But if people notice, your official title is Reverend Dr. Glenda Smith. So you have a couple of different sides from which you're coming at infant mortality. You have your professional side, you're doing education, you're doing the work with community groups such as, the Community Action Team and the FEMA Review Committee, but you also have the faith-based side. How do you combine those things? Is it, I guess, easier maybe because you are on all those sides? You're taking information from your church and maybe your parishioners to, okay, this is what's going on, this is what you need to know, and maybe taking those needs back to some of those groups. So how do you combine all the different hats and programs?
It's a long journey, but I started out in a neonatal nurse practitioner as a neonatal nurse. And so in seeing how babies come into the world prematurely, that led me to move into being a nurse practitioner and again, taking care of those children once they graduated from the NICU. But when you are wearing all those hats, there is a consistency. There's a thread that runs through everything. And so when I'm dealing with the maternal infant reviews, the fetal infant reviews, I'm looking at that from the perspective of what is going on in that particular family, what is going on with the woman, perhaps what has gone on with the infant if they've, been discharged home. And I'm also talking to my parishioners related to their own pregnancies and also helping them to understand about safe sleep and all of those issues that we see. because what I tell them, they can go out and tell their family, their friends who may be having babies. So there's a thread that runs through it all. And while it looks like I'm wearing a lot of hats, I repeat the message over and over again, not only in the clinic where I am today, but also in the review and as well as in the church. Those messages need to get out.
And we do thank you for taking time. When we asked, you immediately said, yes, I can. I wanted to see my patients first, but yes, I will present. So we appreciate that for you, doing both, again, wearing both of those hats of trying to treat and then helping us here pass the information along to everyone that needs it. Okay, so I wanted to ask one more question of you. You mentioned chocolate milk, and I know there's some other resources. Is there a way for us to access that project and some other resources that you have from the Wellness Coalition or other places? Maybe a link you can just share with the audience.
I will get those links to you, so that you'll have them. And again, Ms. Shirley, Daniel pulled this information together for me, and that was the Wellness Coalition documentary. So I will get that link for you, so that you can put it in the chat. Okay.
Thank you very much. And thank you, Ms. Daniel. Okay. Ms. Harris, you mentioned training, reporting, and policy. We do appreciate you leading the committee in all of those efforts. We know how important it is to have that, the training, the reporting, out to the public. And then someone asked earlier about the policies that ADPH works on. So these two programs are how we do affect policy. We can't actually change it, and we're not advocates. That's not our role. We do have limitations, but we are able to provide our partners and those advocates, such as March of Dimes and AMCHIP and places like that, with the information that they need to write policies, where we cannot do that. You mentioned the maternal autopsy program. Is there a way for us to get more information, since we're being asked to kind of support and spread the word? Is it on the website? Because we did share the perinatal website earlier, or is there a flyer or something that we can share?
Yes, we actually did create brochures that we can share.
Okay.
I can provide my contact information, and either I can provide them or April Montgomery can.
Okay, thank you. Okay, let me check our Q&A box. Someone wants to know, when the MMRC reports are published, where could we access those to review them?
They are located on the Alabama Department of Public Health website under the Maternal Mortality Review Program. We can provide that link as well.
Okay. Thank you, Dr. Smith. We have the link to the chocolate milk documentary now. Let's see if there are any more questions in the chat box or... Okay. Another question for you, Ms. Harris. What is the process for adding new people to the MMRC? How are they recruited, chosen? How often are new people added?
So our term limits are for 2 years. After the first 2 years, then they can reapply for a second 2-year term. And then after that, their membership ends until a later time they can join again if they would like to. We will start accepting applications for the next term sometime this coming summer, so of 2022. And you can reach out to me to request an application for membership. And I believe it's also located on our website. And if it's not, then we will get that added to our website as well.
Okay, and April Montgomery, who is our state perinatal program director, has added her email address and Lindsay's email address, and says that if you have specific questions, you can feel free to contact her or Lindsay. Okay, I think we have one more question in Q&A. No, we have answered that. Does anyone else in our audience have questions for Dr. Smith or Ms. Harris today about our maternal and fetal infant review programs? Okay, let's see here. This is a long one. Let me make this a little bit bigger. Okay, Alabama is partnering with 0 to 3's ZTT Building Strong Foundations for Families project, which provides support in development and implementation of infant and toddler policy priorities within the ZTT and class Building Strong Foundations framework. They have convened a public-private core team that meets to support and implement policy goals, develop partnerships, and initiate conversations around equity in early childhood systems. In Alabama, that team includes the Alabama Partnership for Children, Department of Early Childhood Education, Mental Health, Department of Education, Rehab Services, Public Health, and then the 0 to 3. If anyone can assist them with their goals related to improving maternal health and minimizing infant mortality, Ms. Tammy Walker is asking that you contact her. She's the policy director at the Partnership for Children, and her information is in the chat box. Lindsay has also added the website for the perinatal program and the maternal mortality review program. Okay. I think that is all of our questions. Do either of you have any more comments? Anything else you'd like to share from any of your roles, upcoming projects, anything we should be on the lookout for? No? Okay. Thank you. Have a great day.
You too.
Thank you.
All righty then. Our next and final presentation is alternative models of prenatal care. This is a conversation between and about midwives, doulas, and about community education. It will be moderated by Dr. Tiffany Taft, who is the director of Sacred Soul Wellness, LLC. Welcome, Dr. Taft.
Hello, everyone. Can you see me?
I cannot see you yet. I hear you clearly.
Okay.
There you
go. Okay. All right. Well, welcome, everyone. I am going to be moderating or facilitating a panel today that will include 2 of my fellow doulas as well as a local midwife. And so I'd like to take this opportunity to have each one of them give you a brief overview of who they are, but I'll start with myself. My name is Dr. Tiffany Taft, and I am a native of Montgomery, although I have lived many other places after leaving, after graduation for the military. And so I've had several different jobs and lived a lot of different places. As you know, military move a lot. And so I started out in traditional Western medicine healthcare as a hospital corpsman in the military, moved over into health and wellness in 2004. And so I still do a combination of both, but my passion is very much in health and wellness. So as the owner of Sacred Soul Wellness, I offer holistic health services focused on chronic pain and rehab, but specifically my niche is prenatal yoga, prenatal massage, and womb wellness for women on the continuum. So preconception, conception, and beyond. With that, I'll ask Tracy Weaver to introduce herself, followed by Adila. These are the doulas, and then Dana Moore, our midwife.
I am Tracy Weaver. I am a lot of different things. Wow. I'm an evidence-based birth instructor. I'm a birth doula. I'm a spinning baby parent educator. I'm a consumer advocate first and foremost. My major platform these days is birthing rights and training doulas and communicating with care teams in compassion and empathy. I trademarked the concept Keeping Your Power to help consumers communicate with their care teams effectively, so everybody could be on the same page for really great outcomes. And yeah, I guess that's it.
Good afternoon, everyone. I am Adela Smith. As she said, I'm a doula as well as a lactation educator, and primarily what I do, obviously, serving families. I generally work during the pregnancy as well as the postpartum period, serving them, making sure that they're educated throughout the process, making sure that their care is coordinated well, so that they know how to make sure, as Tracy said, keep their power during the process, to encourage healthy outcomes for both mom and babies. And as a lactation educator, I teach lots of breastfeeding classes, not just to families, but to entities that are learning or knowing or wanting to know how to best support their families. And I also consult for different nonprofits.
Hi, everybody. I'm Dana Moore. I am a certified nurse midwife at OB/GYN Associates. I started out as a labor and delivery nurse in the year 2000 and went back to school to learn how to do this job in 2016, I guess, and have been practicing here for 3.5, almost 4 years now. So I do prenatal care. I do well women care. I do gynecological care, birth, postpartum care, and just routine hospital care for my moms after delivery. So yeah, that's what I do.
Awesome. Thank you, everyone. So I want to just jump right in, and for the audience, please feel free to go ahead and start to drop in your questions or comments as we continue the conversation around the alternative models for prenatal care, which I am so excited that Gift of Life wanted to have this presentation and open up the conversation or continue the conversation in a different way, and why this is important, especially now that we're going into the second year of what feels like a forever pandemic. And so I'd like to start out with each of you. If you could just give a brief of how has your jobs and how you move and operate, has that changed any since the pandemic started? And if so, just a glimpse into what that may look like now. Anyone that wants to start?
I guess I want to start. Prenatal care looks so differently now. And I know there are some of my patients probably watching, and they can remember back when we did prenatal visits, the first visit all the way through to the last visit, that we really tried to talk with family support here in the clinic, even down to just going to get that initial ultrasound and seeing your baby on the ultrasound together as a family, as a team, simple things like that. And even me talking about all the things I talk about at the first visit, down to just, diet teaching and stuff like that. We're so used to having that support person here in the office with you. So everybody's on the same page about everything during the just complete orientation of care. Last year, we did that completely solo with the patient only. There was no support person. There was no father, no partner, no nothing. Recently, right before this kind of second wave started, we started getting those partners back into the clinic more and more. And even still now, we are still allowing one person to come in with our moms, which I think is so important, because a lot of times you leave here and I've just given you all this information and you're like, well, I don't remember anything, that she said or what I'm supposed to be doing. So that can always be reinforced with your secondary person, your partner. It's a learning process. We can all learn together. So that's definitely one thing that we're just not really used to as, doing midwifery care. We're just not used to having, not having that family support. And we're trying to obey the rules, and we're trying to do what's right. And so it's a work in progress, but at least now we do get to invite one person into the clinic, which I think is a great start. So.
and Dana, as you said, how things have changed really in the clinic with that other support person being there. I'm I'm on the inside and I'm like, things have definitely changed. While as a doula, I won't show up to appointments. Now I'm on the phone, well, not so much now, but at the beginning of the pandemic, kind of just sitting on the phone, being an extra listening ear during those appointments. Because a lot of times the families that I work with, they got tiny humans at home already. And so who would normally be the person that goes with them into the clinic has to manage the kids. And so they can't even listen in on the phone. So I have to be the second set of ears to say, okay, we covered this, and, possibly sending a text message back. And so how that's changed. So there's that piece. And then there's the hospital piece with the visitor restrictions. Some people have decided, well, I'll go the home birth route. And that's fine too. So that's the attending home births. And I know Tracy can definitely speak to that. There's the attending of home births. And then there's the part where I feel like I'm having to choose between my doula and whoever my spouse or my partner may be. And while I professionally and personally would never put somebody in those situations, sometimes they feel as though, okay, this person may be better equipped to handle this situation, even though they've been educated, even though they've been prepared. We're just kind of having to manage and juggle to see what's going to work best for that family, because now we have the fallout with the care, and maybe the grandparents due to COVID can't come and see after the kids. And so it may be a situation where I'm working with the family and they don't have this large village or this large community of people around them. And it's like, well, the doula can't babysit the kids, so you have to stay with the kids, and the doula is going to come with me to the hospital, and we'll go from there. So things have definitely changed.
Yeah. I had a birth on Monday night this week where the patient's husband was COVID positive, and she is and she's natural birth, and wait till spontaneous labor, and luckily had a friend that was willing to come with her, and because she was feeling fine and she was negative, but it was just so we had Dad on FaceTime, but and he got to see the delivery, but it just wasn't the same for her, and I felt so bad. She did great, but I felt so bad for her. I think worse for him because he couldn't be there for the birth of his child. But, that's just the times that we're in right now.
I think that goes along with the importance of education too. I mean, before the pandemic, I've of course been a pretty heavy educator on the prenatal side, but I think as what y'all were talking about, it really enforces that part that people really need to be educated before, because if a doula can't be there, then now what? And how do I facilitate this conversation without my primary birth support that I have sought out? So that's where my job really didn't really change. It was just more important to me to get them to understand the questions that they needed to ask if I wasn't going to be in a prenatal appointment with them, or could they get across, their desires and their wishes in a way that, was productive. And, me and Dana have worked together before, and it is very different and hard to go through a pandemic when, when you have all these stipulations and things. So working together just in general is just really important, I think, on the surface. And then education was what changed kind of for me.
Mm-hmm. Yeah, I think all of you have made some very great points, and having a solid foundation and being clear is even more important now and as we navigate through a pandemic. And I think one thing that you all have pointed out is we need to help arm the parents, help to empower them to speak up for themselves, arm them with the knowledge that they have choices and they have rights, and they should be honored in those spaces wherever they show up. I think 3 of the particular areas that we wanted to focus this panel on in a fun way, but important way to bring to light or to remind everyone in this space is about education, about the biases that the moms themselves or the families may experience in the spaces that they find themselves in, but also the obstacles around the narratives that are shared about midwives and doulas and where is our place if there's such a thing. We all have a place. We all have a job to do. And how we choose to show up in those spaces is important. We're all educated and we know our lanes. And so I think in the gap of this conversation is how can we all, as health providers, help support our families better? One of the things that I've seen as an experience from some of my clients during this time has been the additional emotional support, I'll say, mental health for those that were diagnosed with specific issues or maybe things that came up as a part of the pandemic. So I like to ask each of you, and I know we kind of briefly as we were preparing, talked about it in our conversation, but what have you seen around the biases in this space, around the mental health? And then how have you had to educate or talk differently around those conversations with your clients and patients?
We struggle with that, with the mental health care. We typically have a pretty good plan in place for that, being that whenever we have a mom struggling with whatever it is, if it's a situation at home that's not good, or if it's a postpartum depression situation, we have people in place to take care of those kinds of things. But now we've had a really hard time getting some mental health care for our moms. We typically, when we have a mom that's complaining of more than just what we think is a postpartum depression situation, when it is like a suicidal, homicidal situation, we directly typically send them to Baptist South for evaluation. And then that's when the mental health caregivers get involved. And we don't have that right now. We're sending patients for evaluation, but a lot of times they're being sent home. And told to follow up, with whoever, whenever. So we're I feel forced to try to initiate something for these moms, whether it be medication or whatever, because that is one thing you cannot let get out of hand. You can't let a mom struggling with depression not get therapy, not get the medication that they need, because that is a very serious problem. And so I don't really know what the answer to that is. It seems like that a lot of the mental health facilities as well, they're not seeing patients in the offices face to face. A lot of their stuff is via Zoom or whatever. And I don't know how effective that is. It's better than nothing. But I would love to hear, any ideas that anyone else has about that, because Haley and I and Charlotte, we're really struggling in that department for some of our patients who are having a lot of difficulties.
Yeah, thank you, Dana, for that. And I think it's important that, to the greater group here and to the context that they have, that this is when we talk about, so the title is alternative, but I really like to say complementary and alternative options, right?
Yes.
What is mental health is important. It was important before the pandemic. It's even more important, I dare say now, especially in this population, because there's so many ways that it can go wrong very quickly. And so how do we get them connected? So if you're in this webinar and you are a professional that can help, and specifically this is your niche, please drop it in the chat or send it to Gift of Life and so they can disseminate, or feel free to send it to any one of us, because we're boots on the ground And we are certainly seeing this more, as we come up and engage with our families. And so wanting them to connect them with the right resources is important. Tracy or Adila, do you have anything additional to add in these spaces?
No, I'll just say foundationally, how can we help with that as doulas? How can we help, the patients that Dana's seeing and any healthcare, any healthcare provider that is seeing these things, how we as doulas can help. Well, one way that I'm helping that is not easy is I am on the Infant Mortality Review Board. And I think that's one of those things that, can be a gap is, yes, we might see something, but okay, what do we do? So professionally as a doula and the people in my circle of influence. So we have to think about, where is our ripple? So if we get overwhelmed on the large scale, let's go back to just our circle of influence. And so, as doulas and who we are face to face with, what can we do for them in our time with them and meeting their need? And that's getting them the help when we see that characteristics are changing, getting them the information that they need on the front side in prenatal care, getting partners the information that they need, getting family members to understand what postpartum depression is, what anxiety is, not to suppress their red flags. And because, depression hits and sometimes a family member is going to see the changes first. I have had dads, contact me first and say, she's not wanting to acknowledge her baby. So then we have to talk the person into even going to Baptist South. And then we have to talk Baptist South into admitting people, like, begging these people to say, no, she is going to not, this is not going to end well. So, in personal responsibility, what do we do? We find the resources and we connect with one another. And I think that sometimes there's just such a gap between, a client, we call them clients and Dana calls them patients, between the patient and where the resource is. And even so, I feel like as doulas, our responsibility is to get with the healthcare providers and with the resources and be that middleman and that bridge to gap that, just like the count the kicks. How are people going to know that, there's this app, and how do I do this? And because, Dana and Haley and Charlene, when Vicki was there, and all the people that have come and go in my 20 years of OBGYN associates in the midwives, there's 5 to 10 to 15 minutes worth of education in this prenatal appointment. And how much pressure is that on a healthcare provider to say, here is this education on nutrition. Here is this education on safe sleep. This is the education on counting the kicks. And if I'm not supposed to do this until the 3rd trimester, but I need to pay attention to this a list of stuff that I need to eat before my glucose test, then I'm not going to pay attention to my kick count. So I just feel like doulas can bridge the gap with education that might not be, coming up, which is nobody's fault, but time and energy and just being overworked. But then in the birth room also, because, nurses know somebody for 5 minutes and have to do their job list too. And so I feel like, the public has got to have like a list of things to know to say, because, pregnant people don't know the questions to ask. They don't know what they don't know. Yeah. And we're expecting them to know things that they have no idea. And I'm being challenged because I ventured into TikTok. And that was really by accident, but my audience has grown, but I'm learning from them. I'm learning what the educational process needs to be, because they're afraid. They don't know the questions to ask. Sometimes there's no time. And so, as doulas, I think that we can bridge that gap a little bit to think small, think simple, and get the relationship with the care provider to be more solid on a solid ground. I think that could be a little bit better.
Yeah, I think all of that is really good, Tracy, and I think a good segue into Adila's space around racial disparities, because I can only imagine it, how things may look now in comparison to a year ago in that space. I would hope that they were better, but I know better. So, Adila, can you share from your perspective, what have you seen personally, or just any statistics you have heard about this space?
Just racial disparities in general. Well, I think, it kind of goes without saying, but at the same time, you can't say it enough. We know what maternal and infant outcomes are in this country. And all the more so, not just because I'm a Black woman, but if they're bad for everybody, if they're rough for everybody, it's generally going to be rougher for Black people. It just is. We know that that's rooted in bias. That's not something you can just kind of walk up and say, oh, I'm going to have a situation where I'm going to deal with bias today at my doctor's appointment, or when I go to this hospital, or at this pediatric appointment, or whatever the case may be. But when we look back at the numbers, at the research shows, and we see that infants, we talk about infant mortality, and that the infants that are Black, your Black and brown infants, are dying at rates that their white counterparts are not. The rate is greater. It's like, what's the cause? When we look back at the numbers, it's like, well, was it the care? Was it understanding or lack thereof when it comes to education? With the mother and different things like that. And then we have to ask that next question, why didn't, if it was a case of education or something of that matter, why wasn't the education accessible? Why didn't this mother, get education, or whatever the case may be? So there's always that. There's always, oh, well, they're just biased, or it's a racial thing, or whatever the case may be. But we have to look at the numbers. Unfortunately, we don't necessarily have a meter to measure bias, if you will, but we have to look at the numbers surrounding what this looks like for this demographic of people, that demographic of people, and everything else. I would love to say that it doesn't impact care, but it absolutely does. And it doesn't matter whether or not a person is coming and they have private insurance, public insurance, whether they are college educated, whether they are married, whether they are single. It's still the same thing, which lets you know, and sometimes it's not even intentional, which is the scary part. Some people are biased on purpose. Some people don't know that they have deeply rooted bias, just because maybe, that's how they were raised, and maybe they don't know that that's wrong. So when you look at educational textbooks, even now in 2021, that still say that Black people don't feel as much pain. You think about that. And so there may be bias in the type of treatment I get if I say that I'm hurting or I'm in pain, or maybe there's a thought that, oh, well, all they do is use drugs, or maybe they're addicted to drugs and they want more pain medication for this or that. And it's like, so not the case. What if I actually am in pain? Maybe I don't have a higher tolerance for pain. Maybe I do need some more evaluation, or whatever the case may be. Like I said, unfortunately, you can't measure bias. There's no, indicator you can walk past and say, hey, am I being biased today? It takes a lot of training to kind of, see for yourself where you are. And then a whole lot of learning and unlearning and then learning to get to that point. There are people who are very, very, very well intentioned when it comes to making sure that they're growing, as well as their coworkers and their practices, or, out at the hospitals and different things like that. But it's a piece of work. And unfortunately, we don't have another, we don't necessarily get another chance to save a patient or to do right by a patient or a family, if you will, if our bias has already impacted their care.
Wow, that's a lot. And all very good and important points to bring forward, in all honesty, because that's how we move forward and that's how we do better is when we start to have real conversations, and stop trying to be politically correct all the time, because these are lives and real people that we're talking about. So I would challenge the audience. I don't know if you got the pre and post questions to the webinar for this segment, but one of the pre question actually is for you guys to name one thing that you have already done to make this change possible. And by this change, I'm talking about having conversations around complemental alternative models of support and care in this space, whether it's encouraging your clients or your patients to seek out midwife care. Definitely every mother that wants a doula should be able to have a doula. But understanding what's the difference. I don't know. I'm sure Dana maybe, but I'm sure the doulas, Tracy and the doula, can say they've had this question at least once. Can you deliver my baby? No. So simple education around what a doula is and what a doula does versus what a midwife does. Well, why do I need both? I'm gonna have to pay for both. Yes, you are if you go that route, just like you pay for an MD, OB, and a doula or whatever other services that you need. Absolutely. It's two separate lanes doing two different types of work, all very important. And so the other thing that I would like to bring forward is, do you think, all of you, do you think that it is important to have these alternatives available? Probably even more now. We weren't thinking about it necessarily in the pandemic. And I can say, we're probably all going to say yes, because we're doulas and midwives. And so we chose the alternative path, however we got here, because we wanted to do something a little different and more holistically, not to say that it's better, but it's different. And it provides options as we have more space to take the time that we talked about, where the healthcare professionals may only have 5 or 10 minutes, and they're really focused clinically on what's happening with mom and baby, and may not always have the bandwidth, even with great intentions, that the education is needed. They just don't have the time. And so that's where we help to fill the gaps. Comments from you guys about any of that?
Yes. So, of course, like you said, we're all going to say yes. I think that's just it's not just our profession, it's our heart. And so then the question becomes, I think somebody like put it in the side or something like that. Like, is it something separate that you have to pay for? Because you mentioned it like about the OBs and the midwives and stuff like that. Right now in the state of Alabama, yes, it's a private pay thing. You do have people like Birthwell, organizations like Birthwell that are based out of Birmingham. And so clients who receive Medicaid or clients of Medicaid, they can get a Birthwell doula for no cost. If they are clients of WIC, they can get a Birthwell doula for a low cost. Here's the thing, because we know it's something that's needed, because it's such a huge piece when it comes to education, and we know there's not enough time in the world to educate families at their prenatal visits with the midwife, at their prenatal visits with the OB. This is where we work together. I feel like this should just be, I know that this should just be like a full-blown continuum of care. It's not like, well, I got a doula because I don't like my doctor. I hope you like your doctor and your doula.
That's a good.
Like your doula and your midwife. I hope you like everybody, because we want to work together. We don't work against one another. We work together for quality care in the best interest of the mother, so that we can have a healthy mom and healthy baby outcome. But there's something to be said evidence-wise. So my background is in biology, love numbers, study math as well. And so when I look at other states where these states have their public and private insurances that cover doula services, and it's only about 3 states. I want to say it's like Oregon, Washington, and I think I may be missing another. I can also look at the health outcomes in those particular places. So whatever we're doing in health in one area, wherever we're trending nationally, it's pretty much the same across the board. When we look at the rates of chronic illness. How do we compare in comparison to the other 49 states? Okay, so all right, Alabama is falling somewhere around Louisiana and Mississippi per usual. We, flip flop back and forth between 47, 48, 49, 50. All right. It's the same thing when we look at maternal and infant health outcomes. Everything else we look at how long, in the case of Medicaid, how long we can have this postpartum care. Is it beyond 6 weeks? Is it beyond 8 weeks? This is where we can take a page from another state's playbook to say, their outcomes look different than ours. What are they doing that we can be doing? Now, we understand that legislative processes are long. We understand that they don't happen overnight. But there's something to be said to say, okay, maybe we can't do something legislative overnight, but what is their Department of Health doing that we don't have to have additional legislation to do to increase better outcomes for our families? In the case of breastfeeding, what is WIC doing in the state of Florida that we could be doing in Alabama that may not take much more of a resource, but it'll just be a better use of our time? Those are the things, that we can look at. And I'm kind of going off on a tangent. Somebody mentioned the Dove grant, and that's correct. Dove is offering a grant for families that are looking for doula services. Y'all don't get me started on my tangent. Y'all go on. Don't mind.
Thanks, Adela. I do want to get to some of the questions in the chat. I've been seeing them pop in, but I can't read them all very clearly. But before I do, because I did see this pop up several times, and I just want to get each of your perspective on the COVID-19 vaccine and pregnancy. And your perspective, have you had to have that conversation? How are your clients or patients, feeling about, are they on the fence? Or they say, yes, give it to me? Are they concerned about it? What are you seeing?
I'm having that conversation with every pregnant patient I see every day. It actually has just become a part of my spill, if you will, for each visit. I would say that over probably the last 2 weeks, I've actually had moms coming in here asking me how I feel about it. Prior to that, nobody was asking me that. And pretty much it was just a very devout no. I don't want to get the shot. As more research is being done, as we see more, maternal death from this virus, blasted on the media, on the news every day, it definitely spikes interest in our patients here. We as a whole, OB/GYN associates of Montgomery, are offering and recommending the COVID-19 vaccination to pregnant women. I think pretty much as a whole, I don't know of any physicians in my group that are not recommending it. We also tell them that if they do become ill and test positive, we want to know right away, because pregnant women are also offered Regeneron, the monoclonal antibody infusion. And the quicker we can do that, the better the outcome is typically. So we are definitely recommending it. I would love for my patients to get it, not necessarily in the first trimester, only because I want the baby to reap the benefit as well as the mom. So if I can wait until the time period comes where my mom could pass on the antibodies to the baby, then it's kind of a win-win. So typically, second trimester and beyond would be my preference on it. But I feel really good about what we're doing here. As of late, I feel like more and more women are responding to what I'm trying to tell them straight from my heart and straight from the research. And more and more are getting vaccinated. And I'm definitely for it, only because I've seen a lot of bad things lately. And I think it helps. So.
Thank you.
I think this is one of those doula responsibilities that we have to really pay attention to too, because we're educators, we're supporters, we're informational. We're not just people who show up to labors and change positions, and we're not just for natural labor. We have to get out of the assumption that, you know, doulas are just for certain things. We're really here to meet the need of the community. That's what doulas are for. So whatever your circle of influence, you know, is. And, you know, so my go-to, of course, I'm an evidence, you know, based birth instructor. So I go to evidence-based birth. You can go to evidencebasedbirth.com/COVID. Rebecca Decker, that is the founder of Evidence-Based Birth, is a nurse with her PhD who has put all of this information in English for consumers, and that's what she does. And so it's, you know, she just compiles the information to put it in one place, which is really handy. If you know, because the, you know, mainstream public doesn't know they're just getting a lot of information. I think that we all are. So having it in that one place, and of course, as doulas, we can't recommend. And, you know, professionally, bias work is really important for every profession, but especially when you are in service work and you're very empathetic to meet a need that is during a pregnancy that is highly emotional. Bias work is really important. So having, you know, places to, you know, be able to send people to, I think is really important, so that they know at least what questions to ask their provider to get in that comfortable zone to even be able to have those conversations, because we're just in a scary time. Anxiety is up in the first place. You know, so I think that's been a really big benefit, but just not being afraid to have these conversations with people too. You know, it's just really important for them to, you know, to have these conversations and to be able to, you know, exhibit agency. And that's another thing that, you know, we're kind of, you know, dancing around with consumers is, you know, what's their responsibility in their birthing, you know, in their pregnancy and their birthing process. And it's to get all the information they need to make important decisions. Mm-hmm. And, you know, we're kind of throwing some stuff at them, but I don't think we're pinpointing, can these people even, do they even think that they have a thought process? And I don't think that a lot of people even think that they have a thought process. Hey, just tell me what to do and I'm going to do it. Or I'm scared of it, I'm not going to do it, I'm not going to think about it. So we have to encourage people to have an actual thought process. Here, this is what's going on. How do you feel about it? How can we work together to reduce your fear and still get a really good outcome for everyone? I think is what we need to. So there was a study that was done that, you know, is in the Evidence of Doula article in Evidence-Based Birth. So it's just evidencebasedbirth.com/doulas. That was primarily done because they wanted to bring out the fact that, you know, institutional racism was a thing. And, you know, we need to interview these people and we need to pay attention to what people are saying. We need to pay attention to our communities. We need to listen to people and what their need is. And in this study, the researchers interviewed, you know, racially ethnic groups that were low income women to try to understand what doula support meant to them. And it was going to help disrupt the negative social detriments of health. But this is what it pointed out. It pointed out that it first found that doulas played the important part of agency. It helped the consumer make the decisions that they were comfortable with. And it lowered the trauma that happens. So there was a study that was done a couple of years ago that said that 1 in 3 birthing people were traumatized in labor. And 55% of those people said it was because they felt a loss of control. So these people were saying that agency made them feel like And we talk about empowerment all the time, but are we really giving people the power to be able to make their own decisions in their healthcare? And then personal security. Doulas helped them confidence level, and they felt secure when they were in front of their providers. And then, saying that doulas were great facilitators. We were communicating, we were helping them communicate, we were showing up helping them communicate. And I've done that even with my clients that were even comfortable with their care providers. It could have been Dana, it could have been anybody else. And if I showed up, if they asked me to come with them, which I was honored to do in the first place, but sometimes they just lost words and they're like, I don't know where to go from here. So communication was better. And then transferring the knowledge, we were able to take what the provider was saying, wrap it up in this easy way for a consumer to understand, because maybe they just weren't getting it. And then just feeling connected and not so isolated. What did we just go through? We went through that we were all isolated. And now we're seeing high anxiety and high postpartum depression and things that we really need to be paying attention to. And this study shows that doulas were helping with that. So I just feel like we need to, personal responsibility, we need to get out there in the community more and get with each other, figure out who's doing what, send people to where they need to be, find your resources and your phone numbers and send people to what you do. But all the organizations that are here, find your doulas, utilize them. The people that are already in this community want to help and they want to be used and they want to be able to use their skills and talents, because all four of us, but all three of us that are doulas are definitely different. Like, you're not going to see me want to give lactation support. That's not my expertise at all. And I'm also not going to teach prenatal yoga, but I am going to facilitate really good conversation and help somebody go to their care provider and build a trusting relationship and get the information they need with evidence-based information, with childbirth education, and knowing their rights and being confident in their ability to make decisions. So I feel like we need to just be better as a community, and all of us, with just collaborating in what each of our skills are that I don't think that we've been really good at.
And Tracy, I want to add on to what you said, because it was so rich. Everything you said was super rich. And I know that the participants that are on here right now are, ADPH, Gift of Life, and different entities that may be around the state and maybe some outside of the state. Speaking specifically to Alabama, those who are having more questions about doulas, and you're learning more as far as what doulas do and how outcomes are improved. And you can find stuff on ACOG, the American College of Gynecology, as far as those hard numbers, especially if you're having to deal specifically in numbers, as far as what it looks like for the people you work with to have doula support. Reach out. There's not a single community in the throughout the state that doesn't have doulas. It might not be me, might not be Tracy, might not be Tiffany, but we're just in Montgomery. There's doulas in Birmingham, Tuscaloosa, Mobile, every major area, and even the smaller spots in between. A lot of us travel within a certain radius. I know a lot of people that work in Montgomery go to Selma when you have people who need help, or who are, who are their families or whatever the case may be. Reach out. If you're trying to create some type of program, I don't know a single doula who isn't willing to get hands-on and say, let me help you with that. If you're one of those sororities, and maybe you have a health committee or something like that, and maternal health, infant health is one of your causes, like the Alpha Rho Zeta chapter. I think it's Alpha Rho chapter of Zeta Phi Beta that has the Stork's Nest. Reach out. I can speak for all of us, even those who aren't present on this call, to say, we want to help. Nobody's just kind of here just like, oh, they don't want help kind of thing. We're here to serve. We have the heart to do it. And whatever it is that you're thinking of, whether you're a pregnancy center or something like that, COPE or a parent resource center, reach out. If this is something that your church or your ministry is considering taking up, reach out. Tracy's amazing. Tiffany's amazing. Like I said, we're just in Montgomery, but there are literally doulas all across this state ready to just show up and insert ourselves, like she said, within the community so that we can have better outcomes. We have better outcomes for moms and babies. We have better communities.
Oh my God, we need more than an hour. Okay. Listen to me, because I think Dana still has patience to see. So I want to get to some of these questions in case there's some that are Dana specific. So moderators, whoever's checking the box, if you could start reading off questions for us, that would be great.
Okay, and please bear with me because there have been a lot of comments and questions. Some of them you've answered, so I'm scrolling up and down. The first thing was we've had a big increase in depressed patients as well. And the comment was that they refer a lot of their patients for behavioral health. They are fortunate to have their own counselors plus AltaPoint. I'm not sure if you've heard of AltaPoint. As a new resident to Alabama, they're finding that there are no resources for mental health and PPD. And they're asking if you suggest the Edinburgh scale or is there another preferred tool? Does anyone want to comment on that one?
Dana might be better at this, but I was going to say in most childbirth classes that are outside the hospital, the evidence-based childbirth class that I teach actually has the Edinburgh scale that they do before, then they do it right after in the hospital, and then they do it after. And actually, everybody that takes my class, even if they're not my personal client, I keep up with. So but I'm sure Dana has better.
No, we use the same tool.
Okay.
I don't really know of another tool, to be honest.
Okay. I think that answers the next one, which was, has anyone referred to an online site or an app for PPD?
I have not. I would love to know if anybody has any information on that, because like I said, we have so much delay in care right now that anything we could do, even, online, would be super helpful to know about.
Okay, and this is more of a comment of thanking you all for being available and willing to support community programs. They were saying that when you have Gift of Life, they're an additional layer of support, and they have the opportunity to add education that the doctors may not have time for, or as you were mentioning early. So they have time to add Count the Kicks or Period of Purple, Crying, Back to Sleep, extra support for domestic violence, depression screenings, and refer. So connecting with you all would be beneficial to their clients. Okay, and then want to address disparities as you are. And thank you for mentioning the reduced costs and free services for doulas for Medicaid moms. Many people were interested in that. And thank you also, Dr. Tapp, for bringing up the question about COVID. And I think that is about it, other than a lot of comments and kudos for you all. There's one thing in the Q&A box. We have answered that. That was just another COVID question. So I think that you can continue. Thank you.
Awesome. Thank you so much. So I don't know about you guys, but I'm certainly enjoying the conversation, and there's much more that can be said around all of these topics and more. One thing that I want to be sure, if I haven't said it already, or one of us has not said it already, we're here to help. We have different areas of expertise, focus, and passions. Mine is specifically all things health and wellness holistically. So for the prenatal moms or those desiring to get pregnant, I'm all about the womb health. Breath, body, and movement is important, especially in pregnancy and after. And so I am all about helping mom manage her pregnancy from her physical body, but also her emotional body, and potentially any traumas that she may have experienced. The others have expressed their areas of passion and expertise. We're all here to help. But we're not the only doulas here, as Adela has mentioned. There are loads of us here. So just connect with one of the three that you see here, or Dana probably even knows other doulas, and we can get you the list. Just like your doctor gets booked or Dana gets booked, your doula is probably already booked for this year. So if you woke up this morning and you found out you're pregnant, now is the time to go ahead and secure your doula for your next year birth, because she books fast. So with that, I want to say, if you are an organization in need of doula support or programs like Doula mentioned, we're here to help support those programs. We're here to move those programs forward. We're here to educate in the community however best we can to help fill that gap. And maybe it's just a reinforcement of things that you've already said. And we've heard people have to hear stuff over and over and over, 6 or 7 times before it sticks to them. So let's keep all saying the same right thing, not making it up. Have the same conversation, right? It may be received better from another person, but you said exactly the same thing. That's all we're saying. So as we begin to wrap up, because I don't want to make Dana late, but I want to make sure she's also engaged in the conversation. I want to ask each of you if you would share at least one thing that you want to leave with the audience, or maybe whether it's the healthcare professional, or maybe it's a mom to be, or someone that's helping to take care of a mom to be. What's the one thing that you would leave them with?
I want to say how much I appreciate everyone in my circle, Nurse Family Partnership, all my Medicaid care coordinators, Gift of Life. I can't do my job without y'all. Y'all have no idea how much I depend on y'all to take care of my girls specifically, and the other ones, in our practice. Y'all do so much, and I am so thankful for that. I just want everybody to continue this journey with me, and let us work together, because it's hard and it's very emotional, obviously, times right now. So we just need each other. So.
Tracy or Dila, do you have a statement you want to leave with the audience? Something impactful.
So the only thing that keeps coming to mind when I sum it up statement, right? I want everybody to remember that all doulas are different. And so when you are looking for doulas in your community, and I'm seeing some links going up, those are just a narrow list of who you're going to see. I would start with whatever community you're looking in. If you're looking in Montgomery, I would, Google Montgomery doula or Montgomery doulas, contact people, and then just start asking questions. The doulas that are the most active, you're going to find. There are doulas everywhere, and we work very differently. Some doulas are only serving their friends and family, because I want you to remember that doulas are not regulated, and we do not have to be certified to work. So there is training, and then there is doulas that go on to do it professionally. So those are going to be two different things also. So if you're looking for somebody to work, with you in a program, and, you want them to be trained a certain way, those are probably going to be like your more active in the community doulas, and you're going to be able to find those people. So there's that. And then the skill level, and then what you're looking for to meet the need of your specific program. Because I was listening to Miss Joy, talk about the program that she's looking at for the Black Belt. You might be looking for something that, Tiffany is great at, or I'm great at, or, I know you're in contact with Holly and Dahlia. So it just depends on what you're looking for your program, and what that doula, because doulas do very different things. The only blanket statement that I can make of doulas is we are non-medical, non-clinical, and we do not diagnose. We are supporters, we are educators, and we want to help bridge the gap between the consumer and the professional.
Mute for me. And I guess what I'll say, absolutely, Tracy, to the people who are support persons, maybe not necessarily those who are expectant, but you're part of the family of the expectant or whatever the support is, you need assistance too. You need to know what a doula does too. You need to know what the role of a midwife is too. You need to know what to expect from the OBGYN as well. You need to know those resources so all of that isn't just on the shoulders or on the mind of the expectant person. Because if you're a support person, it's not just for labor and delivery. You're supporting this person the entire pregnancy, the entire postpartum period. You're there far more often than Dana will ever be, than Tiffany will ever be, than I will ever be, than Tracy will ever be. So if you're on there and your friend, or if you're on here and your friend or your cousin or whoever is expectant and you're close enough in their circle that you know you're going to be a consistent source of support, make sure you know all the things, as we say. Make sure if they plan on breastfeeding, make sure you know what it looks like for them to breastfeed, but for you to be able to make sure that when you care for the baby, that the baby can still get breast milk the correct way. Make sure, hey, I'm not shopping for a doula for you, but I heard this is what you can do, and these are some names. Hey, I heard that Dana is a great midwife. Charla is a great midwife. I think they're over here at this place, and kind of start to have those conversations with them. The more you know, the better you're able to support them. And I can guarantee you, the more they'll lean on you, because mom brain is real. Pregnancy brain is real. Mom brain is real. So just kind of really be their champion. Everybody needs somebody who is 100% head over heels, their champion, always and forever and a day. And if it's somebody that has a personal relationship with them, it makes this process that much more smooth. And again, if we can have a smooth process, then we're going to have good outcomes for moms and babies. We're going to have good outcomes for moms and babies. I saw somebody ask a question. I think Dahlia put it in there about doulamatch.net. Yes, Dr. Bradley, doulamatch.net. Lots of doulas are on there. I think you can search by zip code. Not every single doula is on there. You can post type something in Facebook, and the community you are in, like they said, the community is going to show up and tell you who's who and where. That's generally how most people find me. So that too. And I think somebody was asking what questions might a mom be asking when to find the right doula. Whatever is important to the mom, as far as her pregnancy, maybe she's finding a doula like Dr. Taft. And somebody mentioned something about specific things that we focus on. I focus on both birth, postpartum, and lactation, but I'm also a lactation professional, not as a doula, but I'm also a lactation professional. Tracy is the birth lady. She is the birth queen. She teaches childbirth education. Dr. Tiffany is really full spectrum. She can take you from, preconception all the way through. Literally, I know somebody asked, I think it was Dr. Joy who asked about what everybody focuses on. Some people do just postpartum. It really just depends. It's a doula for every season. But when you're looking for a doula, it is important to know what's important to you and kind of vet the doula and ask those questions from there. I could be here, we could be here giving you a million questions to ask a doula, but whatever is most important to you during your experience, during your journey, you want to focus your questions toward the doula on that. That's your interview.
And that's part of being empowered, right? Interview your doula, interview your midwife, interview your OB doctor, because not everybody's a fit. Now, if they happen to be the only, then you got a choice, a decision to make. But there's options here. So do your due diligence, ask the questions that are important to you, and you'll find out, where the gaps are and if that person's a match for you. I think the one thing that I want to leave community with, I used to be a first responder, so I will say self-care is healthcare. It is important. Make sure that you're taking care of yourself so that you can continue to show up for these mothers and families that need you, because this work is already high stress, traumatized, and now you have a pandemic on top of it. For the birth workers, birth professionals in whatever capacity you walk in, care for the care provider. You can't be ripping and running to every single birth or lactation or whatever it is your thing and not taking care of yourself. Self-care is healthcare. That includes your mental wellness. So get yourselves together. It doesn't have to be a massage. It isn't just go outside and get some sunlight, some fresh air, drink some water, stay hydrated, eat the right things that feed your soul. Moderators, do we have any more questions?
Yes.
Okay.
First of all, I have a couple comments back to what Ms. Smith said about you being full spectrum. I think you just gave lessons to the entire family, not just the mother of the baby. So we thank you for that support. Thank you all for this engaging, insightful presentation. I think we all learned a lot. It was very open and honest and positive and just so helpful. Thank you to the audience they were presenting questions and answering questions. And thank you all for watching that box and just bringing to light the reality of the choices that people are having to make. At the end of the day, we're all here, all the families are here because we want to have healthy moms, healthy babies. We want, safe, complete deliveries. We don't want anyone to lose their life or their baby's life. And just the decisions that people are having to make in this time, as far as you were saying about where to get care, who can come in the room, what's most needed, and just reminding people to take care of themselves and just worrying about that end goal of, having a healthy, safe delivery and a healthy baby. So thank you for all of you for your input and bringing that to the forefront. Thank you all for being advocates. I do have one question. I know that Ms. Smith, you mentioned being a lactation specialist. I know we don't have like a doula registry. I know people are asking for that, but is there a list of other people that deal with lactation and other needs that support the pregnancy and birth and all of that outside of the delivery?
Doulas, OBs, and midwives, we generally have them, but as far as just like one large publicized registry, not necessarily. Just because with lactation, people have different scopes of practice, from educators to counselors to consultants. Okay.
So someone's interested.
I can email you if you would like me to email over some people that I know throughout the state.
Okay. We get questions sometimes. People are like, well, how do I take a childbirth class or an education? How do I become, an educator in this? And I'm like, I don't know, but I'll find out. So any resources you all have to share with me, I will keep them on hand because we will get questions about that. Let's see. There were some other things that came up. Thank you. This is wonderful. More guides. This is great. So I think those were really more comments than anything else. NIH has information available to give clients. If you all want that and they're free, you can download them. There's a phone number. And people are still, and that was for depression. So there's a lot of people really trying to focus on that postpartum depression, or I guess just general depression, especially in this time. Very interesting. Some people said they knew very little about doulas. They are a great assistant to pregnant women. So we thank you all for your presentation. And yes, I think that is it. So I don't see any more questions in the Q&A box or the chat box. Thank you all again for joining us today.
Thank you.
Thank you.
Okay, before we end today, I just want to go back and thank everyone that spoke and presented, from Dr. Harris, Dr. Traylor, Mr. Green, Dr. Gilboa, Dr. Ely, Dr. Collinger at CDC for giving us that great overview of the data, giving us a picture of where we stand in Alabama. Thank you to Ms. Moody at Count the Kicks for telling us about the options available with that program and the success that we're having in the country, reducing our stillbirth rate, and hopefully we'll see that same success in Alabama. Thank you to our community-based organization panel. Again, Dr. Traylor, Mr. Green, Ms. McDaniel, Dr. Bradley. It was good to hear some more about term. You presented for us last year on that project, so we're glad to know that it was able to restart and have some positive outcomes. We know it was interrupted by COVID last year. You had to adjust some things. Thank you to Mr. Johnson for sharing that perspective of a father and just a parent, and even sharing things that your wife experienced and giving us the real picture of the whole family model. Thank you to Dr. Smith and to Lindsay Harris for sharing with us about the work of our fetal and infant and maternal mortality review committees and programs. We appreciate all the work that you're doing to partner with communities and educate them and provide resources and promote programs and the partnerships that you have with those delivering hospitals and OBs and things of that nature. Thank you again to our afternoon panel with our alternative and complementary, I think was what Dr. Tapp said, models of prenatal care. The doulas, midwives, and community education have always been important, but especially in this time where people are looking for options to their deliveries with all the changes that have happened because of COVID. And to all the partners, sponsors, thank you to everyone that helped plan this event. Dr. Grace Thomas, Janice Smiley, Ricky Green, Regina Traylor, Britta Stedegren. She was still working at March of Dimes, and she made some connections for me and told me a lot about some programs that they had going on as far as censoring and the NICU and the Stork's Nest. So thank you to her for sharing that. Dr. Jessica Hardy. Thank you to Ms. Powell and Ms. Brock at ADPH for assisting us in preparing for this event. Thank you so, so much to Ms. Mona Davis at The Gift of Life for all that she did to make this a success. And let me copy this. I want to put this survey, excuse me, into the chat box before everyone leaves. And we will also email that to you all. Do any of our other hosts have any comments while I get that survey? No? Okay. We'll just, if you could hold on 1 minute, everyone, we'll put the survey in the chat box and you can start completing that. And don't forget to send Mona the information that you need to get your CEUs for today.
Yeah,
and I do believe, okay, there's Mona to tell you about viewing later.
I just wanted to add real quickly that following this event, each of you all will receive an email for those who are attendees. And that email will, you'll just respond to it and indicate if you're a nursing professional, social worker, or other professional. So we know what documents to send you. You just complete those documents, send them back. For nurses, be sure that you indicate your full name and your nursing license number. And for social workers, you will receive a certificate that you can use to submit to the social work board. And all others who attended who don't need CEUs, if you want a certificate to just verify that you did attend this event, you will be sent that as well. Just let us know that once you receive the email. That email will go out at the end of the day today, and you'll have about 7 to 10 days to return that information. We're also going to send a link out to all participants sometime next week if you want to rewatch portions of the summit. It'll be available on our YouTube channel.
Okay, the survey is in the chat box. And I also want to thank all of you who sent me pictures. I did get those of you watching the summit, and we will notify you as soon as possible if you have won that prize. Thank you again, everyone, for attending, for sticking with us. This is our fourth time having the summit. It grows every year. I think we get great information every year. I have learned so much today. We work in these spaces every day, and we think we know so much, but there's always so much more to learn and things that we just forget because we are sometimes getting into a cycle of doing the same thing. So I really enjoy these, and they are so educational for me. So thank you all. Have a great day. Continue the great work.